progression-free survival for the patients who got osimertinib was much better than those who got gefitinib or erlotinib. So this graph shows the superiority of osimertinib. The progression-free survival was better for osimertinib in all groups of patients, and you can see the details of the patient population here on this line. The progression-free survival was better for both EGFR mutations, the exon 19 and the exon 21. It means that osimertinib is active in both cases. The progression-free survival in patients with and without CNS metastasis, you can see that the drug is active on CNS metastasis, and the control in the brain was better for osimertinib than for the standard of care. And if there were no CNS metastasis, only systemic metastasis, the same, osimertinib was better than the standard of care. The overall survival, and this is very important, was better, significantly better, for the osimertinib group versus the standard of care group. So these slides show the superiority of osimertinib on other oral TKIs in EGFR mutated lung cancer patients. So we always have side effects when we treat cancer patients, and in this case of the osimertinib and the standard of care, there were diarrhea, rashes, acne, nail changes, dry skin, stomatitis, and the rate was similar for both drugs. Only the efficacy of osimertinib was much better. A picture for relaxation, and we move on. We're now going to talk about FLAURA2. This is a continuation study in the philosophy of treatment of lung cancer patients. What happened in FLAURA2? FLAURA2, patients with untreated, locally advanced or metastatic EGFR mutated non-small cell lung cancer with mutations, as we know from the other trials, they got osimertinib plus pemetrexed and platinum, then continued maintenance with osimertinib and pemetrexed, and on the other hand, the other option of the randomization was osimertinib alone. And patients were treated by this arm or in this arm till progression. What were the results? The progression-free survival was better in the group of osimertinib plus platinum plus pemetrexed over osimertinib alone. The median PFS was improved by 9.5 months with osimertinib plus platinum pemetrexed versus osimertinib monotherapy. The PFS was better for the combination of osimertinib plus chemotherapy in all patients' subgroups. Regarding CNS metastasis, the combination of osimertinib plus chemotherapy was better also in patients with CNS metastasis and CNS without metastasis, but this difference is not very significant. The PFS was better for EGFR mutations for EGFR mutation with all types, the exon 19 and the exon 21, better with the chemo osimertinib over osimertinib alone. The overall survival was better for the combination of osimertinib plus chemotherapy over osimertinib alone. So what was the conclusion of this trial? It was very clear. These compelling overall survival results from FLAWAR-2 confirm osimertinib plus chemotherapy as first-line standard of care in EGFR-mutated advanced non-small cell lung cancer. It means that osimertinib alone is no more the standard of care. It can be given, it can be offered to some patients, but the standard of care now is the combination of osimertinib plus chemotherapy. And this is something new. A picture for relaxation, and there is a question here. Let's see you answering the question, and we move on. The next trial is with a disease that has a chance for cure. The trial is a LAURA. The LAURA, in brief, is patients who had locally advanced inoperable lung cancer. They are offered chemotherapy plus radiation therapy, and then osimertinib monotherapy for 3 years. Let's see how the LAURA trial is built. So the LAURA is a phase 3 double-blind study. Patients with locally advanced, unresectable stage 3 EGFR-mutated non-small cell with no progression during or following definitive chemoradiation therapy. It means that first they got the standard of care chemoradiation, and then if they didn't progress, they were randomized into osimertinib once daily for 3 years or placebo. And let's see the results. Very interesting results. The progression-free survival with osimertinib as post-chemoradiation therapy was very, very significant, very significantly much better, if we can say so, than the placebo. The placebo used to be the standard of care till then. Now we have a new standard of care. It is osimertinib when the patient has the EGFR mutations. The progression-free survival was better for the osimertinib in almost all the patients group. There was an improved trend towards overall survival with osimertinib in this patient population, but the overall survival was not significantly better. And if the drug is so active, we ask why not different? And the answer is that in the placebo arm, 81% of patients with confirmed progression, they crossed over to osimertinib. And since osimertinib is very potent, the survival is almost similar. And that's why the graphs are almost superimposed. In the CNS progression-free survival was better in the osimertinib versus the placebo. It means that the osimertinib prevented development of CNS metastases in many patients. There were side effects, and the most common adverse event in both arms was radiation pneumonitis because of the chemoradiation and the effect of the osimertinib. The majority were low grade, and there were no grade 4, 5, and non-serious, and all the side effects were manageable. The list is almost similar to the list of osimertinib in other trials. So the conclusion of the LAURA trial was that osimertinib improved PFS and protected against CNS progression. Osimertinib has become the new standard of care for patients with unresectable stage 3 EGFR-mutated non-small cell lung cancer who have not progressed after definitive chemoradiation. A picture for relaxation. Take some deep breath and we continue. The next trial is Adaura. Adaura is important, and gave us important advantage that we will see in a minute. We know that in operable disease, the disease recurrence or death following surgery remains high across disease stage in non-small cell lung cancer. You can see here stage 1B, stage 2, stage 3, the recurrence rate is very high. So in this situation, we can tell you that we need adjuvant therapy, something to lower the risk of recurrence. And indeed, we have adjuvant chemotherapy for non-small cell lung cancer. But even when treated with adjuvant chemotherapy, the majority of resectable stage 1B to 3 patients will have a recurrence or will have died within 5 years. So until 2020, the adjuvant cisplatinum-based chemotherapy was the only recommended adjuvant therapy following complete resection of stage 2 to 3A lung cancer. The absolute survival benefit of chemotherapy versus no chemotherapy was only 5%. So you can say this is negligible. Yes, for some patients, yes. But some other patients will do everything to get even 1% of a survival advantage. So in this situation, we have the Adaura trial. It is a phase 3, double-blind, randomized, placebo-controlled, multi-center study. Patients with completely resected stage 1B, 2, 3A non-small cell, with or without adjuvant chemotherapy, but with confirmed primary non-squamous lung cancer with mutations of in the EGFR, the exon 19 or the exon 21. And they were randomized into osimertinib, 80 milligrams once daily, and placebo. This is the standard, the old standard of care for this situation. And the planned treatment duration was 3 years. And let's see the results. Adjuvant osimertinib demonstrated significant disease-free survival and overall survival benefit versus placebo in resected EGFR mutated stage 1B to 3A lung cancer. You see, the blue line is much better than the yellow line. It means that the osimertinib yielded significant benefit in progression-free survival and in overall survival. The Adaura showed that the disease-free survival by stage was significantly better with osimertinib in 1B, in stage 2, and especially in stage 3A. Also, the overall survival was better in stage 1B, stage 2, and stage 3A. So we have a real advantage in the treatment, in the adjuvant treatment of postoperative lung cancer. The CNS disease-free survival was better in patients with stage 2 to 3A disease. You can see that here, this is the CNS disease-free with osimertinib versus the placebo, means that the osimertinib protects the brain from having metastasis. The conclusion of the Adaura were that osimertinib is a standard of care adjuvant treatment for EGFR mutated positive non-small cell lung cancer following curative resection. The overall survival benefit was consistent across all stages of resectable disease. Another picture for relaxation, and we continue. The next trial is the Neo-Adaura. As I told you, it is still experimental. Experimental means that the trial has not been yet completed and not yet been reported, and not yet a standard of care. The Neura-Adaura trial is a global, phase 3, randomized, controlled study evaluating the efficacy and safety of neoadjuvant osimertinib plus minus chemotherapy compared to chemotherapy alone. And this in patients with resectable stage 2 to 3B with N2 disease, EGFR mutated lung cancer. The results were interesting. Interim analysis showed that at 12 months event-free survival, the rate was 93 for osimertinib plus chemotherapy, 95 plus for osimertinib without chemotherapy, and the major pathological response was 26 or 25 for osimertinib-containing arms. So this was much better than chemotherapy alone. These results indicate a favorable trend for event-free survival in the osimertinib-containing arms. Long-term EFS and overall survival data remain immature and are not yet fully reported. So, what have we learned with those trials? We have learned one thing. Osimertinib is effective in EGFR mutated positive non-small cell lung cancer in all stages. So we have a new and very, very convenient agent against EGFR mutations. The osimertinib is given by tablets, 80 milligrams every day, and there is no need to get infusion, no need to go to the hospital, just to have a follow-up of a blood test and treatment of side effects. Thank you for listening.
Professor, thank you very much for your important and valuable lecture. I'm certain that many physicians, many oncologists have gained a substantial amount of useful information here, and your experience has made a significant contribution by sharing this information. Thank you very much. And now we move on to our next speaker, who is quite a frequent guest with us. This is Dr. David Sarid. He's an expert in the field of oncology and serves at the head of Oncoimmunology Service at the Tel Aviv Medical Center. He works together with Professor Mirimsky. Dr. Said is also the lecturer at the Faculty of Medicine of Tel Aviv University. He has published more than 30 scientific papers and publications. He speaks at different global international conferences. Until recently, Dr. Sarid served as the head of the Israeli Oncourology Association, and Dr. Said is one of the leading oncologists in our country. Dr. Sarid, the floor is yours. A very good afternoon, dear colleagues. I'm extremely happy and honored to make a presentation on the latest news on the treatment of the bladder cancer. Today, we will cover new options, new publications we enjoyed recently in the perioperative treatment of muscle-invasive bladder cancer before and after the surgery. We truly have very interesting publications and achievements, and today I'm happy to present all these data, and I will start my presentation with my slides with disclosures. Here they are. My first slide is about stages of the disease. As you probably know, bladder cancer is one of very frequent diseases we diagnose in our patients, and mainly these are males, less females, but to our happiness, bladder cancer very frequently diagnosed yet in the initial superficial form of the disease. Here on the screen on the left, you can appreciate stages of the disease, and 75% of initial bladder cancer is yet superficial, non-invasive, and could be treated using surgery or even local preventive surgery. And then further, we can provide preventive installations using BCG or mitomycin C. These options allow prevent secondary tumor growth in the bladder. And at this stage of the disease, 5-year survival of the patients is very good. It's up to 96%. That is why I could confirm that in this initial superficial stage of the disease, this tumor will not carry high risk of mortality. But if we see invasion of the tumor, specifically muscle invasive stage, then this disease has high risk of mortality, and in the middle quadrant, 5-year survival reaches just 50% in this category of patients. We can appreciate that this is 20% of all newly diagnosed bladder cancers, MIBC, muscle invasive bladder cancer, and this is high risk, and it requires specific treatment, very effective treatment that potentially should reduce this high mortality rate at this stage of the disease. And that's exactly what we are going to discuss today. So please stay with us, and today I'm sharing very important information for this intermediate group of the patients. Main objective of the treatment here, perioperative treatment, is to prevent the recurrence of the disease and the mortality from the metastatic form of the disease. If we look at the metastatic form on the right, we see that mortality here is very high. The 5-year survival is just 6%, and this is palliative treatment already. So definitely we try to prevent metastatic disease, but it's already high risk muscle invasive stage, and here we can cure. So once, as I said before, 20% of all newly diagnosed patients coming to our clinical practice, they are exactly in this stage of the disease, where yet no metastasis, but still high risk of relapse. So after the surgery, almost 50% of the patients come back with metastasis. And also this is 50% survival. 5-year progression-free survival is about 50% in muscle invasive bladder cancer. And if we see the invasion of the tumor not only in the muscle layer, but also up to the subcutaneous fat, which is round, then the relapse rate of the disease is 70% within 5 years. But if lymph nodes are also involved, lymph nodes of the small pelvis, then the recurrence rate would be almost 90% within the next 5 years. That's why this is a really problematic group of patients, and we're always looking for new and effective methods of treatment before the surgery and after the surgery to reduce this very high risk of metastatic disease development. Definitely, you are aware very well with 2 historical publications, which I'm sharing on the screen. So the first publication is of a group of Grossman, published in New England Journal of Medicine back in 2003, almost 22 years ago. In this work, and this is SWOG 8710 study, and the investigator looked at pre-op chemotherapy, which was based on 3 cycles MVAC, and that group of patients, in combination with MVAC and cystectomy. Cystectomy was carried out after the chemotherapy, and the control group were the patients that were immediately referred to the bladder removal, cystectomy alone. This is what you see on the left. And you can appreciate that experimental group, combination of chemotherapy, 3 cycles of MVAC plus cystectomy, here survival is much better versus those who did not get this chemotherapeutical approach. Then the second study, BA06 phase 3 trial. So this is 3 cycles of CMV versus no neck in patients who receive cystectomy. And again, here we see prolonged effect from chemotherapy and the improvement of survival. So these are two pivotal historical studies that actually introduced in our practice chemotherapy before the surgery. Here is a very busy slide. You see some other publication, except publication of Grossman and BI06 study. Also, there is Faserstein and Vesper-Faser-Shalosh, and they again confirm the same, the need to carry out pre-op chemotherapy for the patients to improve their final prognosis and to prevent the relapse of the disease for the next 5 years. Here, I'm happy to share the meta-analysis, and these are meta-analysis of 6 studies made by Vail et al. So totally 2,100 patients were recruited. All of them were getting pre-op chemotherapy, cisplatinum-based chemotherapeutic combinations. And if we appreciate the results of this meta-analysis, so the absolute benefit in overall survival is reaching 5%, exactly in the group of patients with neoadjuvant chemotherapy, cisplatinum-based neoadjuvant chemotherapy, when we compare it versus control that immediately was referred to the surgery. When I'm asked, what's the absolute improvement of overall survival, I'm always giving this rate from 5 to 7%. This is normally what we can reach using standard chemotherapy before the surgery. But what is the challenge of neoadjuvant chemotherapy? So although we improve the prognosis and we reduce mortality by 5 to 7%, but still about 40% of the patients who receive neoadjuvant chemotherapy NAC still have residual high risk of disease, specifically PT2 or P10EN+. So that's quite dangerous situation, because if patients still have residual disease after neoadjuvant chemotherapy, for them average survival would be just 3.5 years, not longer. That is why for all these years we have been looking for something more effective neoadjuvant chemotherapy or something else that could be again more effective than what we've discussed before. We try to strengthen and improve neoadjuvant chemotherapy, adding immunotherapy to that, and here you can appreciate this group of patients. So here cisplatinum plus immunotherapy I am showing with my mouse, but actually you don't see any dramatic improvement in PCR, in the complete response of the tumor. So actually doesn't look very impressive. Yes, there is some, but actually adding immunotherapy doesn't give us much. And here are several publications I'm quoting here. That is why we have been intensively looking the other opportunities to improve the prognosis of these patients. Well, there is another method. If patient goes immediately to surgery without pre-op chemotherapy, maybe then we can add on chemotherapy after the surgery. And here you can appreciate the publication of ABC group of 2022. So this is meta-analysis of 10 studies, almost 1,200 patients. They all get cisplatinum-based chemotherapy in adjuvant regimen after the surgery. And here again, we can appreciate that it also gives us some benefits, and absolute 5-year overall survival difference is about 5 to 6%. But there is another challenge here. This is a serious challenge, because those patients who already had such surgery, which is bladder removal, very frequently are not fit enough. They are not eligible to cisplatinum-based chemotherapy. Let me remind you that cisplatinum is quite challenging treatment that carries some limitations. And for example, if patients has liver enzyme dysfunction before the surgery, then cisplatinum cannot be prescribed, and sometimes it takes time for the patients to recover, to have rehabilitation after such massive surgery. Sometimes there are surgical complications, infections. So yes, it's quite a time to become eligible for chemotherapy, and not all the patients manage that. That's why adjuvant chemotherapy is possible, but it's less used in Israel and around the world. So we always try to prescribe chemotherapy in neoadjuvant scenario before the surgery to improve prognosis, because in this case patients tolerate chemotherapy better, more patients can get chemotherapy, and this is how we improve the prognosis of the patients. But what about adjuvant immunotherapy, you may ask me? And here you can appreciate 3 publications shown in red. So these are 3 publications that double-check the efficacy of 3 checkpoint inhibitors, nivolumab, atezolizumab, and pembrolizumab in adjuvant scenario of treatment. And we can appreciate that none of these publications managed to improve survival of the patients. So none of them showed any advantages in the overall survival, which is a red color on the right, triple no. So 2 options, nivolumab and pembrolizumab, managed to achieve primary endpoint, that means disease-free survival, but unfortunately it does not translate into the overall survival. That is why, unfortunately, adjuvant immunotherapy, it's not a way to prolong patient survival. And that's another publication that I'm mentioning. So this is Niagara study, which used durvalumab molecule, that was the study drug, and it successfully reached the primary endpoint and also gave the advantages in the overall survival. So what are the options which are currently available? So we provide this algorithm of standard treatment to our patients. So in case of muscle-invasive urothelial carcinoma, we give from 4 to 6 cycles DDM-VAC or gemcitabine cisplatinum 3-4 cycles. This is what normally used in neoadjuvant scenario, and only then patients could be referred to the radical cystectomy. And if we appreciate some residual tumor, then some of the patients could be candidates for the adjuvant immunotherapy, specifically using nivolumab. Then there are other options which are not eligible for surgery, not candidates for the surgery. We refer them to the maximum surgical removal of the tumor, which is maximal TURBT, and then there is weekly small dose of chemotherapy and radiation therapy to improve their survival, chemoradiation therapy. So what is the biggest challenge now? So let me remind you our unmet medical needs. First, only 50% of the patients could be cured using our standard tactics, and 50% experience progression. Chemotherapy gives us quite modest survival benefit from 5 to 8%, and mainly it refers only to the patients who are cisplatin eligible. Let's forget about those who are not candidates to the cisplatin, and this is another and rather big group of the patients that unfortunately cannot get cisplatin, and definitely the add-on of immunotherapy, PDL or PD-1 inhibitors to these patients unfortunately did not improve the prognosis. But still we know that yet we cannot enjoy statistically significant improvement of overall survival if we provide adjuvant immunotherapy. That is really pretty sad. So today we can appreciate several big publications. Well, majority of them are not yet in press, so we're eagerly waiting for these results. So the main objective here is to improve the prognosis of the patients, cisplatin eligible and not eligible. So, and here you see 2 parts in this slide, the upper part cisplatin eligible and bottom part cisplatin ineligible. So one of the studies which was already published, this is Niagara study, and I am pleased to speak about it today. That's quite ambitious study, more than 1,000 patients recruited, where the investigator looked at efficacy and safety of classical chemotherapy, gemcitabine cisplatin, plus durvalumab immunotherapy versus gemcitabine cisplatin. But unlike previous publications that we just mentioned before, this time in the Niagara study we can appreciate that immunotherapy was given at the same time with chemotherapy, so 4 cycles together with chemo, and then after radical cystectomy the investigation group continued immunotherapy, durvalumab, almost for 1 year, which is 8 cycles in adjuvant scenario after the surgery. And the comparator arm, the group of comparison, so that's the standard approach. And this is what we do now as a standard: gemcitabine cisplatin, then radical cystectomy, and then just watch and wait, follow up. The primary endpoints that was used to prove the efficacy and safety of this treatment was EFS, event-free survival. That means the course of the disease without the recurrence and without the death of the patients, without the events, which could be classified like that. Then the second important primary endpoint was pathological complete response or complete response of the tumor, PCR. So that means after the surgery in the bladder, we don't see any residual pieces of the tumor that was before that. And another very important endpoint that was used to prove the efficacy is very ambitious objective, overall survival. So what were the study population? So mainly adult patients who were cisplatin eligible with muscle invasive bladder cancer, MIBC, CT2, T4A, N01M0, and these patients are eligible for cisplatin-based chemotherapy, mainly urothelial carcinomas, and also these are patients with renal function or creatinine clearance was preserved, and creatinine clearance was more than 40 milliliters per minute. And definitely we fully understand that this is a very specific group of patients, but it is this group of patients where we are focused on the improvement of prognosis. Looking at the baseline characteristics of the population, we can appreciate that patients who had creatinine clearance more than 60 milliliters per minute were the majority, 81%, but also they were 20% of the patients with creatinine clearance in the range of 40 to 60. This is so-called borderline level, so these are not the best renal functions, but still these patients were allowed to be recruited. If you look at the disease stage distribution, we can appreciate that T2 and 0 was 40%, which is bladder wall invasion, but higher than T2 and 0, which is T3, T4, was actually 60%. So, as you understand from here, we mainly recruited patients with high risk of relapse. And plus to that, 5% of the patients had already regional lymph nodes involvement in the small pelvis, N1. So that's the highest recurrence risk group. Now speaking about the results of Niagara study. Here we can appreciate that standard chemotherapy adding durvalumab gave us high pathological response. That means 37% of the patients after the surgery did not have any residual tumor in the bladder. Then patients who got just chemotherapy, which is cisplatin gemcitabine, only 27% of them had PCR. Besides, if we appreciate event-free survival, which is cause of the disease without events, without recurrence, without the death, and if we follow these curves, Kaplan-Meier curves from the onset all along up to month 62, we can appreciate that durvalumab add-on reduces the risk of recurrence by 32%. And if we look at the cut point of 24 months, almost 60% of the studies of the patients did not recur in the standard group, and almost 68% of the patients did not have recur in chemotherapy in combination with durvalumab. And if we appreciate overall survival here, we can clearly see that durvalumab in combination with gamma reduced by 25% the risk of mortality from this disease, which is dramatic improvement of patients' prognosis, perspectives, and we see that some of the patients could be cured by this approach, and we see that there were 75% of patients cured in the group of standard chemotherapy and 82% of patients in the group of combination with immunotherapy. So again, we see additional 7% advantages that were saved using this combined approach. Some other endpoints shown here, so they were double-checked in this study, so everything was improved. Again, you see metastasis-free survival and disease-specific survival. I will not take too much time diving into these endpoints, but we see that the combination works much more effectively. And even those who did not reach pathological complete response, non-PCR group, where there was not complete eradication of the tumor in the bladder, but again, in the group of combined treatment, the prognosis of the patients in combination also improved versus those who got just chemotherapy. And the same we see in the group with PCR, but much better. So we can appreciate that durvalumab immunotherapy works nicely in this group as well. Now the most rigid endpoint, overall survival, we can appreciate the same. We see very nice splitting of the curves from the very beginning. And in both groups, PCR and non-PCR, we see clear advantages of getting additional durvalumab plus chemotherapy. Now speaking about safety profile and the most frequently reported adverse events, we know that about 20% of the patients have immunotherapy-associated adverse reactions, and we know very well how to manage effectively these adverse events. So immunotherapy is not something new. We know safety profile very well. That's why to us it's not a surprise, and we can professionally manage these adverse events. So such adverse events could be seen pretty frequently in immunotherapy, such as thyroid events, either hypothyroidism or hyperthyroidism, definitely skin problems, dermatitis, rash. We can face diarrheas, colitis, creatinine increase, pneumonitis, very rarely but happen, but all these adverse events, immunotherapy-associated adverse events, are in very low percentage. You see that grade 3, grade 4 was just in 3% of the cases, and mainly majority of reported adverse events were of low severity and could be effectively resolved with steroids. By the result of this pivotal study, FDA very fast in March 28, 2025 approves durvalumab for the combination with standard chemotherapy with gemcitabine and cisplatinum as neoadjuvant therapy for muscle-invasive bladder cancer. And I have to tell you that we're already actively using this protocol in Israel, and I hope very much this combination would be also reimbursed for the Israel patients, and they will not pay it anymore out of pocket, and hopefully it will be done very fast and effective. But now, speaking about the group of the patients who are not eligible for cisplatinum, not candidates for the cisplatinum. So in the first part of my presentation, I was mainly speaking about the candidates eligible for cisplatinum, but unfortunately, we still have a very big group of patients, almost 50% of the patients, and we can see them every day in our clinics who are not candidates for cisplatinum, not eligible. So Niagara results are not relevant for them, because Niagara was actually recruited patients, candidates, or eligible for cisplatinum. So, who are these patients? Cisplatinum ineligible patients. So, these are patients which are ineligible for cisplatinum because of impairment of renal function, creatinine clearance less than 60, or there is grade more than 2 peripheral neuropathy, or hearing loss, or heart failure class 3-4 by NIHA, or very poor functional status, performance status, and they are, let's say, wheelchair-ridden or bedridden, and this is ECOG more than 2, so these patients cannot be eligible for such intensive chemotherapy as cisplatinum. So such patients are not considered the candidates for cisplatinum. So, and this is actually almost 50% of our patients pool, unfortunately. So, what can we offer? So, if we see bladder cancer for such patients, well, unfortunately, we immediately refer them to the surgery, to radical cystectomy. We couldn't provide them any pre-op chemotherapy, and unfortunately, the prognosis here was much worse versus those who were getting pre-op chemotherapy. Here, you can appreciate appreciate European guidelines, European Society of Medical Oncologists guidelines. They actually describe their protocols for patients who are unfit for cisplatin-based chemotherapy, and our European colleagues also refer these patients immediately to the radical cystectomy without any pre-op treatment. So what are the news about cisplatin-ineligible group? And now I'm happy to speak about the new study, Sunrise 4, which was looking at the efficacy of combination of immunotherapy together with a device, which is shown here on the picture. So you can appreciate here, so these are two plastic rings, and here we see chemotherapy, gemcitabine, in these two rings, and it is slowly released from these rings. So these rings are inserted in the bladder, and they are replaced every 6 weeks. And we know that such rings are extremely effective. This is intravesicular system with gemcitabine for the treatment of bladder cancer, which is introduced in the bladder using the catheter and release treatment locally. So patients that were recruited here are the patients with the stage T2, T4A, and 0M0 muscle-invasive bladder cancer and absence of nodal or metastatic disease at screening. So these patients having urothelial carcinoma, predominantly UC histology, and these patients are candidates for surgery after the 4 cycles of systemic treatment. So here you see 2 groups. One group got just immunotherapy, that's control group, and the second group got immunotherapy with TAR2, intravesicular system with gemcitabine for the treatment of bladder cancer. And that's exactly the construction that is introduced to the patient and provides slow release of chemotherapy. Intravesicular targeted releasing system, TAR200, targeted releasing system with gemcitabine delivery. So the primary endpoint is maximum pathological response. We were interested in pathologic CR rate. And the secondary endpoint here is to identify recurrence-free survival and the safety of this approach. Let's look at this result together. So very interesting. If we provide just immunotherapy, then the PCR rate is 28% of patients. But if this is immunotherapy together with TAR200 targeted releasing system, we can appreciate much higher pathological response rates, 38%. So this is complete pathological response. If we look at the secondary endpoint, which is recurrence-free survival, and this is Kaplan-Meier curve of survival probability, you see this combined treatment of TAR200 in combination with immunotherapy is much more effective than just immunotherapy. So these results are very promising, and we can appreciate the introduction of TAR200 intravesicular releasing system could minimize by 36% the chance of recurrence during the 12 first months of treatment. That's a very important result. And I'm pretty sure that we will hear soon more news about TAR200 intravesicular targeted releasing system. Well, from my point of view, that's quite perspective. And we do hope that this treatment will become the routine and would be frequently used in those patients who are not candidates, who are not eligible for systemic treatment by cisplatin. Safety profile of TAR200 in combination with sertralimab. Well, no news. Yes, we have some irritation in the bladder walls due to the chemotherapy, but percentage is really minimal, very minimal. So I believe that this treatment is extremely safe by itself, and most probably it will become routine very soon. But today, we are living in the area when we have absolutely new perspective and breakthrough group of treatments that belongs to ADCs, which is antibody-drug conjugate. This is a new weapon in the treatment of metastatic urothelial cancer. So they are focused on several receptors on the surface of the cell. Here, schematically, you you can appreciate most important receptors, for example, Nectin-4 receptors, HER1-3 receptors, TROP2 receptors, HER2 receptors. So these are exactly the receptors we want to influence using new breakthrough candidate molecules, and we can appreciate the results of clinical trials shown here that are checking these new options in the metastatic scenario of the disease, and definitely we are double-checking all these treatments in the perioperative phase of the disease. So we want to double-check that these options are not simply effective in the metastatic form of the disease, but also they will be quite effective in the perioperative stage of the disease. One of the best examples of these novelties is enfortumab vedotin, or PADCEV. We call it briefly as an acronym EV, enfortumab vedotin. So in fact, enfortumab vedotin is a weapon which is moving directly to the malignant cell. Why is it a missile? Why is it a weapon? Because here you see a chemotherapeutical load. So this is MMAA. It's like taxane-like chemotherapy. Besides, this chemotherapy is connected through the linker with the main construction of this conjugate. You see its antenna-like construction. So that's exactly the antibody that is bound to the surface of the tumor cell. So as soon as it is affiliated with the tumor cell, we see the release of chemotherapy, which is actually killing the tumor cells. So that's very interesting molecule, antibody-drug conjugate. And enfortumab vedotin already proved its efficacy and safety in multiple publications, specifically in the later stages of the disease, in the metastatic stage of the disease. You can appreciate incredible overall response rate in these patients in the second and in the third line. So that was efficacy in monotherapy on enfortumab vedotin and also in combination with pembrolizumab. You can appreciate here by EV103, and this is combination with immunotherapy. We see that 73% of the patients respond in the very late stages of the disease, heavily pretreated patients, and we didn't enjoy such results for quite a time. So I'm extremely happy that this effective option is available now, and definitely I'm happy to remind you about another publication which was presented at ESMO Congress 2 years ago. This is EV302 Keynote A39. So that's a combination of enfortumab vedotin in combination with pembrolizumab in the treatment of the previously untreated metastatic bladder cancer. You remember this study, EV302, EV plus Pembra, and here you can appreciate dramatic improvement in PFS and OS versus standard platinum-based chemotherapy. We appreciate that this treatment in the first line of the disease almost doubled progression-free survival and also almost doubled average survival, so 16 months instead of 32 months. So this is really phenomenal results of the median OS. So we didn't see anything like that in the previous decades. And this treatment is effective in all groups of the patients, specifically highly active regardless of PD-L1 status, with liver metastasis, those who are eligible and not eligible for cisplatinum. So cisplatinum eligibility also doesn't matter. So you see that all groups of patients are lucky, and combination of EV plus Pembra is working effectively and safely. When we have such effective treatment in the metastatic form of the disease, definitely we are happy to look at perioperative effect, and I'm happy to share the results of publication shown 1 month ago in the Asthma Congress. This is keynote 0905 or EV303. More than 850 patients were recruited here. So, and all these patients were cisplatin ineligible, so they were not candidates for cisplatin. So let's appreciate the results of this study. On the left, you see key eligibility criteria and the design of the study. So one group of patients was getting a combination of enfortumab vedotin and pembrolizumab. So this is a combination we just spoke about. So totally they got 3 cycles of combination before the surgery, then radical cystectomy and PL&D, and then 6 more cycles of combination, and then the rest of the cycles, up to 14 cycles, pembrolizumab as a mono, as a maintenance. So the second group was referred to right to the surgery, and then pembrolizumab as a maintenance up to 14 cycles. So what were the patients who were recruited there? So this is clinical stage T2, T4A, and 0M0. Or more than 50% of them had to have urothelial histology, cisplatin ineligible per Galsky criteria, performance status from 0 to 2, and the primary endpoint here was to prove that the combination of EV plus Pembra improve event-free survival and overall survival as well. So let's appreciate baseline characteristics here. So we can see that patients with poor functional status ECOG-2 were about 12 to 14% of the recruited pool of patients. Patient cisplatin ineligible, so those who met the inclusion criteria were 83%, but also there were some patients who were candidates and were eligible for cisplatin, 16%, but they refused from chemotherapy. That's why they were also recruited in this study. Let's appreciate the tumor stage at baseline. So mainly patients with quite advanced form of the disease, which is T3, T4A, and 0. So almost 80% of these patients had T3, T4, not T2, because T2 is just the bladder wall invasion, but T3, it's already invasions into the abdominal fats and neighboring organs, T4. And also there were actually 5% of patients with involvement of the lymph nodes N1 into the small pelvis. So summing up, we can say that the patients that were recruited here were quite advanced. Let's appreciate the results, really stunning results. We didn't see such results for decades before. You can appreciate here primary endpoint, which is event-free survival by BRCR criteria. So no recurrence of the disease. You see the splitting of the curves from the very beginning, and this is very sharp splitting of the curves, looking at event-free survival during 60 months of follow-up. And you see that the hazard ratio is 0.40. That means we can reduce this risk of recurrence by 60%, 60. And this is really phenomenal, stunning results, which we didn't see for many years before. And if we look at overall survival data, we can appreciate that the group of combination EV plus Pembra managed to show 50% reduction of mortality risk. So not 5, not 6, not 7, but 50% mortality risk reduction. So we never ever saw that before. Let me also add on here that PCR, which is pathological complete response, complete eradication of the tumor from the bladder, is reported also in 50% of the cases. We never saw it, even if we provided cisplatin-based chemotherapy, so we never saw such high rate. We know that cisplatin could give us maximum 47%, but 57% is something stunning. What about safety profile and treatment-related adverse events? Well, we should fully understand that there is particular price of combination. That was very active treatment, and definitely here we see higher rate of adverse events in EV-Pembra combination versus those who were referred immediately to cystectomy with no systemic treatment. So on the right, we see higher grade and higher rate of adverse events, but we know how to manage, how to control adverse events. We are not afraid of them. We know how to manage. So to us, it's not a challenge to manage patients professionally. Now, speaking about other studies that we are eagerly waiting for, and this is phase 3 Volga study, and we were recruited in Israel as well. So here it's mainly focused on the patients who are cisplatinum ineligible, and we are eagerly waiting for the results of Volga study to be double sure that the tactics we are selecting proves again the efficacy and safety. And besides, we are expecting EV304 keynote B15. So that's the study which is quite similar to the previous one which I spoke before. Again, it double checks the combination of EV plus Pembro versus gemcitabine plus cisplatinum, standard chemotherapy. Well, Israel was also involved, and this study is already closed, and we are waiting for the processing and for publication of the results. But this is a group of patients who are cisplatinum eligible, and that's why we are waiting for these results to see how EV plus Pembra works, again, cisplatinum-based chemotherapy. Let me appreciate here another work, and we are also waiting for the results. And this is perioperative phase of the patients, and this is Chinese option, dizitamab vedotin in combination with immunotherapy, toripalimab, in patients who have muscle-invasive bladder cancer, stages CT2, T4A, N01, and M0, and this is again neoadjuvant treatment, as you can appreciate in the design, then radical cystectomy, and then immunotherapy could be continued for up to 20 cycles after the surgery. So we are waiting for the results very eagerly. So this is vedotin, but not enfortumab vedotin, but dizitamab vedotin. And by the way, here patients have HER2-positive muscle-invasive bladder cancer. So these patients eligible for radical cystectomy and pelvis lymph node dissection. So mainly this combination is checked for these patients. Why we are waiting so eagerly the results of this study? Because the same Congress, ESMO Congress, 1 month ago, Berlin 2025, this combination was also presented, but in the first line of locally advanced or metastatic urothelial carcinomas. And we can appreciate that the results are very similar to EV-Pembra results that were presented a few minutes ago. So, and we appreciate that overall survival here is almost double here due to such fantastic combination, DV and T. So we are expecting that this treatment will also be effective in the stage of the disease that we are talking about today, which is in our focus today. And what about the future? Well, I think the future belongs to genome stratified therapy. So in the future, we will select patients by their genotype and genome stratification. So we appreciate several publications here, and they're double-checking this theory, so I don't want to dive very deep in there, because these are still very experimental projects, and yet we have no results. But I do hope that after the publishing of these works, it would be a great honor again to present this data and to tell you that today we can have much smarter choice, much more precise choice, selection of patients, selection of those who can get maximum benefit from pre-op treatment. So, summing up, wrapping up, coming to the conclusions. Combination of perioperative durvalumab and cisplatinum-based chemotherapy is the new standard of care in cisplatinum-eligible patients. Combination of perioperative enfortumab vedotin and pembrolizumab is the new standard of care in cisplatinum ineligible patients. not candidates for cisplatin-based chemotherapy. And last but not least, our future is biomarker-guided selection. So we will enjoy some personalized variants of therapies, and trials are on the rise. So in each patient's personal, looking at his or her pattern or genomic signature, we would be able to select personalized therapies. We are at the very beginning of this very long journey, but very hope we'll be proud that we can do it. With that, I thank you very much for your attention, and I'm extremely grateful for your participation, your attention, and hope seeing you again. Dear doctor, thank you very much. As always, very interesting and crystal clear presentation of the information. So I'm always pleased to listen to you as a lecturer. Well, thank you very much, and I'm always happy to be involved in the Israel Med Day conference, because this conference increases the professional awareness of our colleagues, and we also frequently invited to Russia, to the Russian Oncology Congress, which is carried annually, and frequently we make presentations there. And I'm happy that with your help, we also could provide the best and most recent news to our colleagues in Russia and in our countries. So yes, we have broadcast for the old post-Soviet space very many doctors from Russia, Uzbekistan, Ukraine, Belarus, Tajikistan, Baltic countries. Yes, because we have always at least 70 colleagues enjoying our broadcast from Israel. So yes, we are very popular, and this is continuous statistics. The average broadcast rate and connection rate is at least 70. So we have two questions to you, and I'm happy to ask them now. In what cases do you think neoadjuvant chemotherapy is a must in bladder cancer? And is there any group of patients where neoadjuvant does not provide any benefits? Yes, as I said before, we should always look at the stage of the disease. If you appreciate, both in Niagara study and in Keynote 303 study, which I presented here, we are saying that the patients, big groups of the patients, are those who are quite advanced in the disease, which is T3, T4, and 1. So those patients where we have highest risk of disease recurrence. That's why these patients are getting maximum benefits. Patients with initial stages of the disease will not get such benefits. So I don't recommend such options in the patients with very initial stages, with superficial stages. And if we are not quite sure, the doctor is not quite sure, or the patient is not quite sure, then right now sometimes we carry out genetic analysis, which is called ctDNA, circulating tumor DNA. This is blood test which is looking for the fragments of tumor DNA in blood. And if we see these fragments of ctDNA, then these patients have high risk of disease. And to these patients, I strongly recommend to get neoadjuvant chemotherapy together with new treatments to minimize the risk of relapse. So this is the test which we currently enjoy in Israel. It's available, ctDNA, circulating tumor DNA, and I have patients where we made this test and we found high risk of relapse, and we recommended to get treatment. Thank you very much. And we have another question here. What's your approach to the adjuvant treatment after radical cystectomy, especially if we appreciate minimal residual disease, MRD, or unfavorable pathology, histology? Yes, this is also quite problematic group of the patients. As I said before, up to 40% of the patients still have quite bulky residual tumors after the surgery, and they have normally very poor prognosis. So we all doctors and oncologists, we are trying to provide adjuvant treatment as well after the surgery, as I said before, after radical cystectomy. So we can offer immunotherapy to these patients, immunotherapy based on two treatments, which is nivolumab and pembrolizumab, and they could postpone the relapse quite effectively. And we do hope that at certain stages we will see the features of life expectancy increase. So yet published data did not show that, but in any case, I still believe that there are patients where there is special sensitivity to immunotherapy, and they could effectively give us complete response to immunotherapy. That's why I always try to prescribe immunotherapy to such patients, because these are exactly the patients with very poor prognosis, and we are always looking for new methods of treatment to improve their outcomes. Thank you very much. Thank you very much, dear doctor, for your presentation, for your answers, and we hope seeing you again. Thank you very much. Have a good day. Take care and goodbye. And now I move on to our regular expert, Dr. Irina Zhiviluk. This is a doctor who I value, respect, and I have known her for many years. This is a doctor who, in my view, never experiences any professional burnout. She is always available to help patients at any time of day or night. Practically 365 days a year, she consistently comes to help to patients and successfully helps them to extend life or achieve a long, high-quality remission and recover. Dr. Zhiviluk is the head of the daycare unit Asuta Ramada Khayal Hospital, which is the flagship of this network of medical institutions. She is also the head of the Breast Cancer Treatment Institute of this network, Suta Clinic. Her clinical focus and the areas of interest include clinical oncology, breast cancer, ovarian cancer, and cervical cancer, as well as the use of modern chemotherapy and targeted therapy regimens. She is the author of more than 20 scientific publications. She is a regular speaker at different international conferences. Dr. Zhiviluk is a member of Israel Medical Association, the Israel Association of Oncology, and the American Society of Clinical Oncology. Dr. Zhiviluk, the floor is yours. A very good afternoon. My name is Irina Zhiviluk, and Mark has already introduced me. I deal with breast cancer already for more than 12 years, and I'm the head of the Breast Cancer Oncology Service at Asuta Medical Centers. My lecture is supported by AstraZeneca, as today we are going to discuss new treatment options which are based on newly found mutations in breast cancers. Few words about epidemiology. As far as we know, breast cancer is the most frequent tumor in females. It is the first by incidence, and it is the second by mortality. And it is not just due to the fact that ecology changed or some external factor changed in the world. No, it is exclusively due to two factors only. First, the evolution of medicine, development of new pharmacological treatments, and the second thing that we should not forget of is the longer with time, the more females know, are aware, and they follow the recommendations of the healthcare professionals, and they come for the regular checkups early enough, and the majority of breast cancer cases are diagnosed early enough. So this tumor could be seen also in males. For 100 female breast cancer, we have 1 male breast cancer. And as you know, more than 2/3 of breast cancer tumors are estrogen receptor positive. This is something we can be proud of, or this is something we can be lucky. Only 4% of newly diagnosed breast cancer is stage 4. And after such optimistic statistics that only 4% in Israel have newly diagnosed metastatic disease, let me show you less optimistic statistics. So regardless of the fact that the majority of patients are coming to the doctors and they start treatment not in stage 4, but still we know by 20-year follow-ups that 1/3 of females who come with stage 2 of estrogen-sensitive breast cancer, the disease will recur, so later on they will come with metastatic disease. But if we speak about stage 3 of EBC, on average half of them who actually got correct treatment at stage 3 initially. They will come later and they will recur in the metastatic scenario. So what are our objectives when we treat metastatic breast cancer? Unfortunately, regardless all types of treatment options or technologies, it's too early to speak about cure. Although up to 10% of females with metastatic breast cancer can potentially be considered cured, but majority of the patients desire to have longer life. Definitely, we would like to improve or maintain their quality of life, to control symptoms as much as possible. That means complaints because of the disease. Improve quality of life. That means minimize the symptoms, minimize pain, improve appetite, improve functional status of the patient, and finally prevent serious complications of both disease and treatment. So, summing up, we want to prolong life, maximize survival time without worsening of this quality of life. What do we have to take into consideration when doctors, and not only in oncology, in fact, in many medical specialties, start treating patients? So there are three starting points. First, the patient considerations, patient factors. We have to take into consideration age, functional status, ECOG, mobility. We should see what happens in the family, what happens around, the drugs that patient is taking, not related to oncology, concomitant treatment. Definitely, we should take into consideration the disease, the status of the disease, what's the tumor burden, what are the symptoms, what's the type of the disease, and then we move on to the drug treatment. Until a recent decade, or maybe even longer, drug treatment was mainly based on two parameters: the status of the disease, the stage of the disease, so that means how many malignant cells we see currently in the human organism. And in the recent years, before we design particular treatment strategy, we also should look at tumor cells, not at traditional staining only, which is done in any lab for the last 60 to 70 years. Now, we have to take into consideration genomic characteristics of the tumor, different mutations that could be seen in the primary tumor or at the stage of metastatic disease, because later on, as we know, tumors, they are growing, they mutate, they escape immune control and surveillance, and we should go back every time to check what we're treating, because it guides us how we should treat these patients. In the recent years, we enjoyed new studies, which is NGS analysis, next generation sequencing. So this is detection of mutations in cancer-related genes at any stage. So there are multiple mutations that are either congenital or acquired. So here you see three main mutations which are extremely important in the metastatic hormone-related cancer, which is PIK3CA, ATM1, and PTEN. So these three mutations, or better say, treatment of tumors with this type of mutations, would be in our focus today. What are the standards of breast cancer treatment for the last 10 years? So the first line of treatment of the metastatic hormonal-dependent HER2-negative metastatic breast cancer, as we all know, is endocrine treatment, ET, or anti-estrogen treatment, adding CDK4/6 inhibitors of cyclin D. So there are several options, but this is combination of two options, which is standard now: endocrine treatment plus CDK4/6 inhibitors, and that was the most powerful, at least until now, last 2-3 months. So we use anti-estrogens and CD4/6 inhibitors continuously until progression, until they stop controlling malignant growth. At the moment of the disease progression, so when tumor cells become resistant, we have to switch, we have to change the treatment. At the moment of switch, this first line of treatment in metastatic scenario, the question is, what is next? And again, we have to retest HER2 status because we know that the tumors can be not only HER2 positive or HER2 negative, they could be HER2 low, so with low level of HER2. And currently, we have options that could effectively eradicate HER2 low type. And in the endocrine sensitive tumors, we should check the mutations PIK3CA for the last few years, as we see options alpelisib and nivolumab. Also, we are checking ESR1 mutation. So this is sensitivity to hormonal treatment, BRCA mutations, and the rest, because the list of mutations is in fact very long. Here, I would like to draw your attention to the main pathogenetic mechanism of malignant cells in hormone-sensitive breast cancer. So, AKT, which is here in the center, is a key enzyme in the signaling pathway from PIK to PIK-mTOR, which regulates survival and metastatic behavior of breast cancer. Activation of the signaling pathway happens through PIK. Then its AKT pathway moves to membrane, then phosphorylates together with mTOR, and finally becomes active. After the phosphorylation, we see the increased activity. The main function of AKT is to prevent apoptosis. So that means these malignant cells do not die, and their division and growth is stimulated. So in parallel, this signaling pathway plays a key role in the glucose metabolism. So overactivation of PIK, AKT, and mTOR caused by the mutation leads to the development of tumor and uncontrollable division of tumor cells. And later on, it mediates resistance to multiple therapies and reduction of apoptosis. Let's appreciate how PI3K inhibitors are working. So in nivolumab and alpelisib, we know how it works, but until recently we couldn't influence the whole chain of events. PI3CA, ATM, and ESR. Now we are enjoying capivasertib. Capivasertib that influences three key forms of phosphorylation proteins. Capivasertib is blocking both PI3K and AKT and P10. So this is triple block. So this is how it blocks the proteins that initiate mechanisms of uncontrollable division and facilitates apoptosis. So that means capivasertib refers cells towards apoptosis, towards cell death. So the drug capivasertib, which is TrueCap, it's a small molecule in two doses, 160 and 200 milligram. This is a small molecule with a half-life period of 8.5 hours. The recommended dose is 200 milligrams BID twice a day, days 1, 2, 3, and 4 every week, and then 3 days off. So if we look at 1 week treatment, so patient is 4 days on and 3 days off treatment. So when can we start the application of the drug in oncology? Definitely only when we have reliable data on the efficacy and safety and the recommendation of the treatment to particular groups of treatment. So this is pivotal study, which is the basis for the registration by the regulators. Is called Capital 291. So here they recruited patients with HR positive, HER2 negative breast cancer. So totally about 700 patients who were recruited. Well, main patients females, but few males as well. So Here, patients who had recurrence or progression after the first line of treatment of metastatic disease. So investigated, recruited patients with just hormonal treatment and also those who got combination of hormones plus CDK4/6 inhibitors. Half of the patients were randomized to fulvestrant anti-estrogen treatment second line, and the other half was getting placebo for 4 days on, 3 days off, and half were getting capivasertib in the dose which was recommended, which is 400 mg BID 4 days on and 3 days off. So treatment was provided until disease progression, like in general oncology, without scientific restrictions. So the primary endpoints shown here. First, they wanted to see is progression-free survival, so the time from the start of treatment until the progression of the disease, PFS, progression-free survival. The second endpoint was overall survival, ORR, overall response rate, and definitely safety profile. If we appreciate Kaplan-Meier curve, we can see that in this study, with more than 700 patients recruited, all the patients, both who had mutation in one of 3 genes, PIK, ATM, and PTEN, you see the time from the start of treatment until the progression of the disease. Those who were getting combination almost doubled versus those who were getting standard treatment. Patients who were previously exposed to CDK4/6 inhibitors and those who did not have prior CDK4/6 inhibitors gained in time until progression. Those who had prior chemotherapy or who did not have prior chemotherapy, here we can appreciate that the group that did not get chemotherapy, here the difference is bigger versus the ones who had prior chemotherapy. Here the difference is smaller. And when we speak about overall survival, which is the most rigid endpoint that all patients, oncologists, specialists, and the whole community is interested in, if we look at overall survival data, we can appreciate that those who were getting combination of treatment with capivasertib live longer versus the ones who had monotherapy. What about safety profile and adverse events? We can appreciate that those who were on dual combination, capivasertib plus fulvestrant, had higher rate of any adverse events, which is easy to explain. Also more serious adverse events, but if you look at the percentage, it's 16% of any serious adverse events for the metastatic patients. It's not high. If we appreciate the bottom part of this slide, you can appreciate that temporary interruption or final discontinuations rate were very low. Majority of the patients successfully continued treatment. What are the most frequent adverse events? Diarrhea. But please appreciate, grade 3 diarrhea was reported only in 12% of the patients because diarrhea grade 1 and 2. So this is normally diarrhea that has minimal influence to the quality of life and easy to manage or to prevent. So severe diarrhea was reported in a minimal number of patients. Then increased glucose, hyperglycemia was seen 4 times more frequently in those who were getting combination. And as I said several minutes ago, capivasertib could influence glucose metabolism in the organism, but again, severe hyperglycemia was not reported. Stomatitis, like in any biological treatment, and definitely we see it more frequently versus the monotherapy group, but general safety profile of biological treatment, biological molecule, small molecule, capivasertib versus other biological options was very, very favorable, and adverse event was very low, adverse event rate. So this is actually one of the reasons that led to the massive use of this option, and it was prescribed more frequently than the other drugs from the same group. So summing up data on capivasertib, we can confidently say that this new option provided statistically significant and clinically meaningful improvement of PFS, progression-free survival, improved survival of the patients for those who were treated by just hormonal treatment and for those who were getting combination of hormonal and CDK4/6 inhibitors. It could be combination of capivasertib with anti-estrogenic treatment, so very rare severe adverse events. This treatment considered to be safe and effective. So based upon this data, we started using this option 2 years ago, and now it is widely applied all over the world. Just one word, because medicine is evolutionizing, and now the standards which are currently available may not be relevant for tomorrow. Currently, you see ongoing study of capivasertib in the first line of treatment as add-on to the standard protocol, and we are eagerly expecting, and we do hope that the triple combination appears to be much better versus the standard, which up to now, which is anti-hormonal treatment plus CDK4/6 inhibitors. But this study is still ongoing, and you see identifier at the bottom, and definitely we are expecting improvement of safety, tolerability, improvement overall survival and PFS. And as I said from the very beginning of this lecture, definitely we want to prolong life for these patients. We don't want to risk or minimize their quality of life, and it may sound like cliche in oncology. Now they say that we have to help patients to continue living with oncology disease but not die from cancer. Thank you very much. Thank you very much, dear doctor. So very interesting and not very simple. We can truly appreciate that medicine as a science is moving forward actively, and the most important, that we are happy that it helps the patients, and with each year, with each several years, we appreciate true progression in the treatments, and there are few adverse events, and the effectiveness is getting higher. Is it true? Yes, correct. If you give me one extra minute, I can tell you that for the last 20 years, oncology changed dramatically. Because when I started dealing with oncology, which is 25 years ago, metastatic cancer, no matter which one, that was sort of a capital punishment, that was dead end, so that was one-way ticket. But now, in many metastatic diseases, these metastatic patients live like chronic patients for years and decades. Really incredible, awesome. Now we have several questions to you, dear doctors, and let me read them. So the first question is about your final remarks on the new drug. What are the clinical advantages of new option versus available existing options of treatment? Here I would like to emphasize one of the most important factors: adverse events. Adverse events and not the best safety profile of previous options, because previous options that came to oncology and they were used massively and they worked nicely in oncology, but actually majority of the patients couldn't take them long because of safety profile, because high adverse event rate. Because if we have the drug that helps to more than half of the patients, but again 2/3 of them cannot take it, not only just in Israel, all over the world, when 75% of the patients cannot stay long on treatment because of adverse events, definitely we understand that this drug that we as doctors, as humans, do not want to recommend, because nobody wants to minimize metastasis, improve the CT or MRI, but the patient is bedridden with reduced functional status. So it's not always something which is nicely demonstrated in the scientific publication is widely applicable in practice. Capivasertib with better tolerability, so people can function, they can live, they can continue their employment. So capivasertib doesn't prevent them from living, so they continue normal living. Now we switch to tablets in oncology, everywhere, in chemotherapy, in biological treatment, in immunotherapy. So we stop bringing patients for prolonged IV infusions. So everything which can be done in a tablet, that's great. So patients take these tablets at home and can live happily and function effectively. So that means comfort of treatment, if I can put it this way. Yes, absolutely. That means great help to radiologists, minimize the tumor and kill the patient. So this is how we can call previous options. Next question, dear doctor. How frequently do we see mutations PIK3CA, P10, and AKT1 in patients in metastatic hormone positive HER2-negative breast cancer? If we speak about the incidence, so the percentage of mutations, 1 out of 3, sometimes reaches 40-50%. But it is very important to mention that these mutations could be acquired. So that means if we check the primary tumor, it is negative. Sometimes we take the biopsy of the first metastasis and it's negative, but at the moment of the progression, a few years later, when there is a question about next line of treatment, we again double check because these mutations can pop up because some of them are acquired. The tumor is acquiring them in the progression, so they are not congenital. So now in oncology, we check the mutational burden more frequently, so at every tumor progression. So we take new piece of tissue and again we retest. So that means secondary new disease. I wouldn't call it a new disease, it's a new type of the disease. So if at first there was no mutations in 2023, but it could be found in 2025. And now I have another option of treatment. I have another way to treat patients which I never had before, capivasertib. How frequently do you see it? Any statistics of acquired mutations? Well, it is not so frequent. I hardly can speak about these statistics because for each gene, this mutation rate is very different. But from the example of other diseases, not only breast cancer, we do know that these mutations could be acquired with the progression. So the disease is progressing, that means it's being mutated and becoming resistant. And there are new mutations and we find out about them, and now we see something new. They were never detected before, and now we detect them, and now we have treatment. And I always explain the females, the patients, that the patients live longer, that one specific drug is better. No, they live longer because a tumor would be resistant to any type of treatment, so it is becoming resistant and evolutionizing, and here we need new options. So the tumor will always progress, but there are situations when the patient is cured and the drug managed to kill and eradicate some cells and metastasis. Well, there are situations when the patient is cured clinically and radiologically and even from the laboratory point of view, when the retests, let's say once within a few months for several years, give us no information about any viable tumor. But if patient was diagnosed with metastatic disease at any moment of life, so the approach here is the following. If we don't see the disease, if we don't see pieces of tumor, it doesn't mean it's not there, because there is a definition of micrometastasis. That means conglomerates of malignant cells, which are microscopic, which are undetectable now, but they're still there. Well, there are different methods of studies, blood tests that are now more and more frequent in oncology. For example, they are looking about the double-strand DNA ruptures and the fragments of malignant cells by the peripheral blood test, but yet it's quite far away from the routine practice, from the ideal world. So we consider any metastatic disease as a chronic disease. as incurable disease. So the drug works, then we continue treatment, like hypertension, like any chronic disease. So if the drug reduces your blood pressure, that's good. You can take it for 20, 30 years. We never stop. If it doesn't work, so we switch. We switch to another treatment. Well, God save the patients. Hopefully that will become chronic disease and patients will have many years of life ahead. So if it happens, let it be chronic, but not fatal disease with unfavorable outcome. My next question, a bit long one. What changed in the safety profile in this new generation of drugs against PI3K, and how the tolerability is different from the previous options, because they were not taken by many of the patients because of adverse events? Well, partially we already answered that question, because what we want is to control the quality of life. We don't want patients to suffer. And for example, if we see increased glucose level in peripheral blood, let's say in several folds or dozen of folds, when we first prescribed first options against mutations in the genes we spoke about today, PIK3CA, P10 and AKT. So the first options where we had great hopes, great expectations, but we cannot apply them widely because the glucose is increased several times because of severe skin manifestations, adverse reactions that sometimes require hospitalizations. And with capivasertib, with new options, we don't see all these negative effects. So that's extremely important. So that's extremely favorable safety profile. So here the efficacy and safety is at a very high level. So because we want the patients feel comfortable and they can continue that lifestyle they have started with. And if this is a symptomatic disease, if, for example, there is a tumor mass that gives the pain syndrome, definitely we would like to minimize the pain and improve quality of life. Got it. Very clear. Thank you very much, dear doctor. With that, we will hope that all the drugs will be effective and safe, exactly like capivasertib. Thank you very much, and hope seeing you again. Thank you for the invitation. I wish the science to be developed and evolutionize. Now we know more and more, but we find more and more as well, and we all hope that in the future the medicine will become even better and people will live longer, and one day probably will manage to cure. Thank you very much. Thank you and have a good day. Goodbye. And right now, I'm happy to introduce our doctor hematologist, Mia Zekter, and she's from early age in Israel. Her Russian is not as brilliant as in the previous speakers because she graduated school and the medical school already in Israel, but she presents you fantastic information. Dr. Zekter is dealing with plasma cell malignant diseases. She has been working in the Soroka Medical Center, which is university clinic at the very south of the country. She also had courses of continuous medical education in Canada and one of the leading world centers for myeloma treatment. And also in Soroka Clinic, she established specialized myeloma clinic. Dr. Zekter, in her activities, is specializing on the innovative methods of treatment such as CAR T cells, and she's promoting the availability of this treatment in the periphery, in the regions. Beersheva is periphery, although it's 100 kilometers from Tel Aviv and 100 kilometers from Jerusalem. Doctor is actively involved in the clinical trials. She also teaches at the Faculty of Medicine, Beersheva University, and she is a senior lecturer at different international conferences. Dr. Zekter, the floor is yours. Thank you very much. Thank you for giving me this great time and opportunity to offer these multiple treatments of multiple myeloma. And today I will make my presentation, and I will be happy to get questions at the very end. So I will mainly be speaking about CAR-T in multiple myeloma, clinical experience and conclusions. So that's my outline of the presentation. We'll speak about the modern paradigm of myeloma treatment of relapse refractory multiple myeloma, and with a special focus of immunotherapy, CAR-T therapy, efficacy and toxicity, adverse events. I will show you the clinical case from our hospital. We will be talking about the sequencing of therapies in relapse refractory multiple myeloma, RRMM, and also we speak about future directions in the treatment. So, multiple myeloma, just a few words about the disease as it is. It's still incurable hematological malignancy, which is characterized by the clonal proliferation of malignant plasma cell that finally secrete dysfunctional M protein that gets into serum. This is the second in the prevalence among hematological malignancies, and we expect, as it was estimated, about 36,000 new cases of multiple myeloma per year, and also expected 36,000 new cases in the United States in 2025, and the median age at diagnosis is 69 years old. Here you can appreciate International Myeloma Working Group criteria for the diagnosis of multiple myeloma. It should be active or symptomatic disease with the presence of the proliferative disorders with plasmatic cells, and one of the features or characteristics of active disease, which is called CRAB criteria, which is C, calcium elevation, R, renal insufficiency, A, anemia, or B, bone disease, more than one lytic lesion by X-ray. That's what we can see also on CT or PET-CT. This is CRAB, CRAB criteria. But since 2014, even if the active symptoms of myeloma are not reported, but if there is a big tumor mass, let's say more than 60% of clonal cells in the bone marrow, or abnormal ratio of the free light chains, more than 100 involved kappa, or on MRI, if we have any lesion, focal lesion more than 5 millimeters in size, that we know that this patient will progress to active myeloma for the next 2 years. That's why we call it active myeloma. And yes, today the guidelines says that we need to start treating these patients. Here you can appreciate natural history of multiple myeloma. Here on the left, you see absolutely asymptomatic stage, which is called MGUS, or smoldering myeloma. MGUS is approximately 4% of population 40 plus, and majority of them will never progress towards multiple myeloma. Those who do progress to multiple myeloma, to active myeloma, so we start treatment with them, and we start first line of treatment, as shown at the bottom of the slide. As you can appreciate, there are relapsing fluctuations of this disease, so we start treatment, patient gets into remission, then we see another relapse, we start second line treatment, then again new remission, then again relapse, and again treatment and remission, etc., etc. But finally, patient reaches a refractory stage, and unfortunately, no treatment available here. So, and sometimes it could take from 4 to 20 lines of treatment. As you can appreciate, the longest remission is reached when we provide active and effective first-line treatment, and then remission is shorter and shorter with the further lines of treatment. Now, the paradigm of multiple myeloma treatment. Well, first, we perform diagnosis and risk assessment. So we recruit young, healthy patients, and we are saying that they're eligible for transplantation, which is the method of cure. Because if this is transplantation eligible, then first we provide induction, and it could be protocols with biological treatment. Then consolidation stage would include bone marrow transplantation, and also high dose of chemotherapy. And finally, the maintenance. All patients after bone marrow transplantation continue maintenance treatment. For the stem cell transplantation ineligible elderly patients, comorbid patients, they are not candidate for bone marrow transplantation. That's why all of them will get induction followed by continuous treatment until disease rises up and reaches new relapse and refractory disease at the end. At the bottom you see the tumor burden. First we manage to minimize it, and in the remission period it's very low and sometimes undetectable, but it always comes back, and mass is always increasing, especially at the refractory stage. So we can say that, yes, it's easy to select first line of treatment because this is more or less standard, whether the patient is eligible or not eligible for stem cell transplantation, SCT. But what can we do when the disease relapses, and which factors influence the treatment choice? The first are patient-specific characteristics. It all depends on the performance status, age, frailty, relevant comorbidities, lifestyle, adherence concern, patient preferences, and caregiver support, because there are very elderly patients saying, leave me alone. I'm happy to live 1 year, 2 years with good quality of life, and possibly you will find some future treatment or something else that patient could get at home without visits to the hospital. On the other hand, I have disease characteristics. I should analyze what disease is refractory to, because I cannot repeat those options of treatment if the disease is already refractable. So I have to look at the disease burden, the rate of progression, because sometimes the treatment takes 1 month to be ready, and patient cannot tolerate this month, because if we see very aggressive disease, then I need to prescribe something else, and then I need to understand how aggressive should I be. If I look at the cytogenetics of the patients, if we see the disease not only in the bone marrow and beyond. Also, I have to take into consideration the regimen of treatment besides extramedullary or myeloma-defining symptoms grabs. So can I maintain therapy to progression or intolerability, or I should at least include one agent from a new or non-refractory class? I should look at the reaction of the patients, what is the response, seeking maximal response, and the factor of treatment itself. I should look at adverse events, because, for example, there are patients who are continuously suffering from infections, from myelosuppression. So if I give them something now that could simply kill them, it's very dangerous. Definitely access, cost matters, the route of administration, and plan for treatment, because I have to anticipate subsequent treatment lines, because we appreciate more and more new lines of treatment for myeloma. Now, locomotion study. So this is the real-world practice, real-world study assessing the outcomes. Totally 248 patients were recruited that got, in median, 4 prior lines of treatment. Some of them up to 13 lines. The range is from 2 to 13. So actually, all patients were triple-class exposed, proteasome inhibitors, IMiDs, and anti-CD38. Actually, all effective and available options, and the patients were already pre-treated. So we tried to look at their prognosis with the traditional options of treatment before the new innovations came, and we appreciated that the overall response rate, so the chance of any reactions to treatment, is about 30%, and here we see the progression-free survival, PFS, is just 4.6 months, less than half a year, with an overall survival median of 13.8%, and more than 50% of these patients experienced severe adverse events, higher than grade 3, and again, majority of them died because of disease progression, due to disease progression. So we fully understand that for these patients, the prognosis is extremely poor. Here you can appreciate that since 2021, we have new drugs and new treatments. Majority of them are immunotherapies, and also new methods of treatment which are approved for the treatment of multiple myeloma, specifically for these patients which experience multiple relapses after several lines of treatment. And when we look at efficacy, so here on the left, you see the options that could have been provided just a few years ago. You can appreciate that's exactly 30% of efficacy and progression-free survival, which is here 4 months and not longer. But since 2020, 4, we appreciate new technologies, especially BiTEs, bispecific antibodies, and CAR T cells that provide us phenomenal results, as it is shown here, and we can appreciate dramatic improvement in patients' survival rates. So, what myeloma is? Why immunotherapy works in myeloma? Because myeloma is in fact failure of the immune system, dysfunction of the immune system. So, how can we redirect immune system to target the plasma cells? So, the first technology, very innovative and modern technology shown here on the left, which are CAR T cells, chimeric antigen receptor T cell therapy. So, we collect blood from the patients, then we redirect T cells, we process, then we multiply CAR T cells in the laboratory, and then these redirected and multiplied T cells are returned back to the patients. So these reprogrammed cells could eradicate myeloma cells. So that's the first technology we're going to talk about. And the second technology is called BiTEs, which is bispecific T cell engager therapy, and they are bound with T cells and with myeloma cells. You can see this linker. So if this BiTE, bispecific antibody, one arm of this target antibody is linked to CD3, which is on the surface of the T cell, and the other arm would be related to antigen like BCMA or GPRC5D, which is in the surface of the myeloma cell, and then finally it actively pulls together and activates T cells to eradicate multiple myeloma cells. With every new technology, we appreciate new adverse events, which we never appreciated with the standard treatment, which was provided for many years for myeloma. And some of them, first of them is called CRS, which is cytokine release syndrome. And very frequently, patients clinically demonstrate fever, hypotension, tachycardia. Actually, the manifestation is quite similar to sepsis and could be sometimes very severe, requiring ICU, but these cases are very rare. Severe cases are very rare. The second very specific adverse effect for immunotherapy is called ICANS. This is immune-related neurologic toxicity after BiTEs and CAR Ts. So here you can appreciate confusion, tremor, speech difficulty, and sometimes it's really severe. Patients may experience seizures and sometimes can get into coma. But normally it is reversible in 95 and 98% of the cases. Also, we appreciate cytopenia with prolonged neutropenia, and it is prolonged the risks for infections. Here we can appreciate more infections versus standard treatment. So normally it happens because of poor immunity and could be viral reactivation like cytomegalovirus, CMV. And last but not least, we can appreciate hypoglobulinemia, very low level of immunoglobulins and antibodies, and sometimes we need to return to inject immunoglobulins back to them. Let's dive deeper into these two fantastic technologies, and first I'm speaking about are BiTEs, bispecific antibodies, as it is shown here. What are the advantages? They are actually off the shelf, so they're available in the pharmacy, and if I need to provide this treatment, I just order it and my patient could start the treatment almost immediately. As I explained before, these antibodies on the one hand are linked with CD3 on the surface of the T cells and also antigens on myeloma. And there are two antigens, which is called BCMA, and the second one is called, for the drug talquetamab, it's against GPRC5D. So two options, teclistamab and elranatamab, they are against BCMA antigen, and talquetamab is against GPRC5D. So all these three options, three medications are FDA approved for the treatment of adult patients with relapse refractory myeloma after 4 prior lines of therapy, including proteasome inhibitors and IMiDs, as well as anti-CD38 monoclonal antibodies. Here, I'm sharing the efficacy of this treatment. These 3 options shown here, elranatamab, teclistamab, and talquetamab. So the decision was made after pivotal clinical trials, phase 2. So in all 3 bites, the overall response rate, which is a top line, is approximately the same, from 60 to 70%. In case of elranatamab, which is on the left, which is anti-BCMA, the duration of the control could be a little bit better than others, about 17 months. This is median of PFS. 2 other options, elranatamab anti-BCMA and teclistamab anti-BCMA, the median of overall survival reaches almost 2 years, 24 months in the median. And the most interesting, those patients who responded to treatment, we see in the clinical manifestation and in the lab tests within 1 and 1.5 months, we see that the median of time to relapse is 1.2, 1.5 months. So initially, patients were very severe, and if we prescribe this treatment late enough, definitely the results are worse versus milder patients and earlier start of treatment. Speaking about adverse events, so here are BiTE therapy side effects. For 2 anti-BCMA options, which are elranatamab and teclistamab, the safety profile is very similar. So again, we appreciate cytokine release syndrome, CRS, which I spoke about before. We can see it almost in 60 and even 70% of the cases. But again, any grade higher than grade 3, it's less than 1%. Like in majority of the patients, they would appreciate tachycardia or fever without any side effects like hypotension or difficult to treat condition. But that is why normally for the first dose we hospitalize these patients in order to escalate the doses consecutively. So this is within 5 to 7 days of hospitalizations where we started. As you remember, ICANS is neurotoxicity. This is immune cell-associated neurotoxicity syndrome. Actually, we saw quite low rate of that, so we never saw it higher than grade 3. Any other grade was a little bit higher with talquetamab, which is against GPRC5D. Then anemia, about 30%, thrombocytopenia, about 20%, infections, about 40%. Also, we can see infections about 40%, and the third bispecific BiTE antibody, which is talquetamab, gives us lower infection rate, just 16%, but here we face unique adverse events, which is rash, dysgeusia, and nail change, and also xerostomia. Dysgeusia, the taste change, so they feel like eating paper, and that's why we frequently see weight loss in these patients, almost in 62%. Right now, in clinical manifestation, we see that some of the patients, rarely, but it happens, have cerebellar toxicity with talquetamab. Let's speak about the other technology, which is CAR T-cell therapy. I will explain it a bit wider, how it looks like. First, leukocytes, WBCs, white blood cells, including T cells, are separated out from the patient's serum, and the rest of the blood is returned to the patients. Then, finally, these T cells are sent to the laboratory. Then, in the laboratory, these T cells are reprogrammed using viral vector. They add on a special receptor here, which is called CAR. That's why we call this treatment CAR T-cell therapy. And then, finally, these CAR T cells can recognize and eradicate tumor cells. It looks like training of T cells to recognize and eradicate tumor cells related to myeloma. Then, in the body, after the preparation, we should give a little bit of chemotherapy to calm down the immunity of the patient. So we call it lymphodepleting chemotherapy. Then CAR T cells are infused back into the patient from lymphodepleting chemotherapy. So they find and eradicate tumor cells, and these CAR T cells could circulate in the human organism for several years. This is how they protect from the further relapses. Currently, we have 2 FDA-approved CAR T cell therapies, and if this is antigen, it's anti-BCMA, and something on the left which is called ide-cel, and on the right it is cilta-cel. 2 options, both CAR T cell therapy. So the first pivotal studies were carried out recruiting very severe multiple refractory patients, almost the ones I showed you in the first study, locomotion, so patients after the previous at least 3 lines of treatment. But both options, ide-cel and cilta-cel, showed very high efficacy. Here you can appreciate ide-cel, and this is KARMA study, shown on the left, demonstrates overall response rate of 73%, progression-free survival median 9 months, and overall survival about 2 years. So you remember these results that we had at the very beginning with our standard treatment. If we appreciate data on the right, and this is cilta-cel, and pivotal study was called CARTITUDE-1, here you can appreciate overall response rate 98%, and PFS almost reached 35 months in very severe, heavily pretreated patients, and we can appreciate that 1/3 of them were without progression more than 5 years. Well, we cannot yet call it a cure, but this is phenomenal result, and overall survival, again, more than 40 months. For the last 2 years, we appreciated CAR T at earlier stages, at earlier lines of treatment, and this is how phase 3 clinical trials were carried out, and it proved that the earlier we prescribe CAR T, ide-cel or cilta-cel, the better are the results. If you appreciate KARMA-3, when ide-cel was provided with 2-4 prior lines of treatment refractory to last regimen crossover, so overall response rate was 71%, progression-free survival median 13.8 months, and overall survival here in median has not yet been reached because these studies were carried out last in 2 years. Now CARTITUDE-4, which is on the right, so this is a prescription of cilta-cel to patients with 1 to 3 prior lines of treatment refractory to lenalidomide, and patients were eligible for cilta-cel. We see overall response rate is 85%, progression-free survival longer than 30 months. We never saw such results before, and overall survival is not yet reached here. So, when FDA appreciated these results, so they in fact allowed these indications, they said that ide-cel could be prescribed after 2 or more prior lines, including proteasome inhibitors, IMiDs, and anti-CD38 monoclonal antibodies, and cilta-cel could be given after 1+ prior line of treatment, including PI or IMiDs, and refractory to lenalidomide. That's the inclusion criteria. So these are the news all over the world, and now we are trying to help our patients, especially very severe patients. Now let's talk on the safety profile of CAR T cells. Let's look at side effects. So if we speak about CRS, which is cytokine release syndrome, well, here the rate is pretty high. You see in both treatments it's 80%+, but again, severe options, grade 3 or higher, which required noradrenaline or something else, it was no more than 3%. ICANS was reported almost in 15% of the patients, and only 3-4% had severe rates. immune cell-associated neurotoxicity syndrome icons. If we compare with bispecifics, well, here the rate is higher, but that's not so dramatically. Neutropenia is reported in 90+% of the patients, and majority of the cases it's higher than grade 3. And yes, here we appreciate pancytopenia even 1 month after finishing of CAR-T. Thrombocytopenia, about 50% of the patients, neutropenia grade 3, almost 90% of the patients, infections here, almost 50 to 60% of the patients, but again, severe infections, about 20% cases. And with CAR-T, we sometimes see secondary malignancies, specifically hematological malignancies, and it was a little bit higher than in the control group. But these are patients who were heavily pretreated with multiple lines. Some of them got melphalan as a part of bone marrow transplantation strategy. Well, we still follow these results, but we can appreciate that, yes, secondary malignancies rate is a little bit higher in CAR-T versus BiTEs. We also observed delayed neurotoxicity. Also, we saw neurocognitive changes and dismovement. And when the treatment was moved to the earlier lines, and when we provided good bridging therapy that I will talk about later on, then we appreciated much lower rate of these adverse events. What are the eligibility requirements? So what requirements the patient should meet to get this treatment? So in order to get cilta cells, we have to see that patient is refractory to lenalidomide, and currently in Israel we can provide both cilta cell and ida cell. So main requirements shown on the right. So it should be good organ function, cardiac, pulmonary, hepatic, renal, because it would be very difficult to perform this procedure with severe cardiac or pulmonary failure. So right now we do it to the patients with renal failure already, and even dialysis patients. We have to be sure that patient has normal mental health, social support, as well as dental clearance. Patient is free from infections, no alcohol, drug abuse, and it is very important that there is someone available as a caregiver to support when we need to follow the symptoms like temperature or some other complications. So we need to have somebody next to the patient. So this is our plan for CAR-T treatment. First of all, it should be properly planned and scheduled. So if patient is relapsing, we should provide some treatment, but this treatment should be stopped at least 2 weeks before apheresis, before the collection of the cell, because we don't want to damage the activity of these T cells. So before apheresis, it's better not to provide chemotherapy like alkylating agents or bendamustine, because it could damage T cell function. So it's break for 2 weeks, and we try to avoid alkylators, bendamustine, or polychemotherapies or TCEs. So as soon as apheresis is done and cells are harvested and we send them to the lab, we have at least 1 month whilst the T cells are redirected and properly processed. And then we need to make a decision about bridging therapy. This is some sort of treatment after apheresis whilst waiting for CAR-T cell therapy. First of all, our goal is to avoid worsening and clinical deterioration of the patients, and also this bridging therapy could effectively reduce the disease burden, the tumor burden, and then it will improve the results of further CAR-T treatment. And then we can use CAR-T cell infusion as soon as they are ready. So normally, normalization of the immunity, and we use fludarabine and cyclophosphamide. Sometimes we can provide bendamustine if patient has renal failure. Let's appreciate CAR-T therapy process. As I said before, first, we are double-checking patient in advance. We include laboratory tests. They should be updated. We check the organ function and disease restaging. And then we see the patient is ready. Then we involve the patient and the caregiver education, then apheresis procedure, then patient returns home post T-cell collection, and then within the treating hematologist or oncologist, we are scheduling bridging therapy for the next 30 days, and we are waiting for the T-cells to be ready. As soon as the T-cells are processed and redirectors, normally we hospitalize patients and we admit the patients, we put central catheter, we provide 3-day lymphodepleting chemotherapy, so that's very short course of chemotherapy to calm down the immunity, and then we provide CAR T-cell infusion, which takes from 10 to 14 days. Well, definitely, if we appreciate severe adverse events, it could take longer time. Then we see stabilization of the patient, and we ask them to monitor different parameters at least for 1 month after CAR-T treatment. So, as a minimum, during 2 days, patient should have regular blood counts because it could be cytopenia, which is delayed later than 1 month. Also monitor infections, temperature. So we should look at the myeloma profile, what was the reaction of the patients, and then approximately within 1 month, patient could easily go home. So as soon as FDA approved this treatment, they had very stringent requirements. So the requirement was to stay next to the hospital for at least 4 weeks, to the hospital which provided the treatment. Now this limitation is just 2 weeks. And it was not allowed for the patient to drive car after CAR-T treatment for at least 2 months. Now it's just 2-week limitation period. So majority of the patients, as soon as they are discharged, they can happily go home if they don't live locally, and they can drive car. So now driving restrictions are minimized and reduced from 8 weeks to 2 weeks, and we monitor requirements of the parameters, pressure, pulse and temperature for 10 days. Definitely, we provide infection prophylaxis and vaccination. First, it includes antibiotics, and normally we provide acyclovir or valsiclovir against herpes virus. If there used to be previous Hep B, we also provide prevention. And speaking about antibiotics, normally we give Resprim against PJP. PJP prophylaxis is recommended. First of all, before CAR-T treatment, we recommend perform vaccination, including anti-flu, anti-pneumococcal, anti-COVID-19, and this is not just before the CAR-T. The same is before treatment with bispecifics, and you can appreciate that after CAR-T, we strongly recommend to repeat the vaccination once again. Normally, we didn't add on any other antibiotics, only if we appreciate very long and very severe neutropenia. So, if we make the comparison between these two technologies, well, CAR-T takes time. We need 1 month for the cell preparation, so it's a delay of 1 month, and it's immediate, off the shelf. So, CAR-T requires bridging therapy, so before, after the harvesting and before the return. For bispecific antibodies, no bridging is needed. I start treatment almost immediately. The efficacy is very high for CAR-T, and also very high, maybe a little bit reduced in bites. So CAR-T given only 1 time. This is 1-time infusion after lymphodepletion. But for bispecific, patients should come continuously, first once in 1 week, then once 2 weeks, then it becomes once a month, and then patients come to the hospital and getting these antibodies. Hospitalization in case of CAR-T takes 4 to 14 days. In case of bispecific, we require hospitalization during the first 5 to 7 days because we should escalate the dose because of cytokine release syndrome and ICANS, which is immune effector cell-associated neurotoxicity syndrome, and chemotherapy before treatment required in case of CAR-T and not required in BiTEs, and efficacy in general could be a little bit higher with CAR-T. Now let me briefly present a case. That's the patient from our center. This is a man, age 69, married, father of 2, who lives in Arad, which is approximately 45 minutes drive from our Bershev Medical Center. So this is quite remote area of living. So in his medical history, we appreciate obesity. Also, there is sleep apnea. He is using home CPAP treatment, also ischemic heart disease. Back in 2020, the patient experienced myocardial infarction, diastolic dysfunction, plus pulmonary hypertension, diabetes mellitus, BPH, very severe peripheral neuropathy grade 3-4, which developed with myeloma. His performance status, as you appreciate, is pretty low, ECOG-2, although he's pretty young, 69, but because of this severe peripheral neuropathy, it's difficult for him to walk, especially massive walking, so for him only short distances are available, and he needs some help of the third party at home to cook, to clean, but the rest is functioning. And on the right, you see very impressive list of current medications. So this is classical elderly person. Diagnosis of multiple myeloma was made back in 2013. Patient had multiple lytic lesions, skull involvement, no anemia, no renal failure or hypercalcemia. We didn't see high-risk cytogenetics, so that was normal risk cytogenetics, so patient got local therapy, skull radiotherapy and vertebroplasty, because patients have some lytic lesions in the spine as well. So he started first-line treatment in April 2013. Patient received what was possible at that time, so that was Velcade, cyclophosphamide and dexamethasone. So at that time, 12 years ago, he was much younger, and patient was eligible for bone marrow transplantation when we continued Velcade maintenance after the autologous transplant. So the result was fantastic, complete response, but developed severe neuropathy, probably as a result of autologous transplantation and Velcade. Then, 4 years later, we experienced progression and we started second line of treatment that was available at that time in 2017. So patient got daratumumab, which is anti-CD38 antibody together with Revlimid, and the patient achieved complete remission within 2 months. So again, reaction was great, but he felt really poor. His neuropathy was getting worse, so he had diffuse body pain, burning feet, back pain, diarrhea with Revlimid, fatigue. That's why patient stopped lenalidomide in 2 years, and then in 2020, he stopped daratumumab, especially after the cardiac event, non-STEMI, non-ST elevation myocardial infarction. Probably it was not related to daratumumab, but the patient was tired of treatment already. Then, a few years of silence, and then patient progressed and started third line in August 2023. Actually, we re-challenged him with daratumumab. He was not refractory because he was just tired of treatment, and at that time, we put it together with Kyprolis, which is second-generation proteasome inhibitor, but patient stopped Kyprolis due to toxicity, dyspnea, high blood pressure, and patient stopped it. But just daratumumab was not enough because the disease continued progressing. This is how we start fourth line, and we added pomalidomide, and still slowly and steadily patient continued progressing. So if we conclude about the status of this patient, patient actually is exposed. That means he got drugs of all 5 classes. So his refractory rate to the rituximab and pomalidomide is pretty high. And although patient is young, he's 69, but I believe he is full of comorbidities. So his frailty score is frail. By CCI, he gets 7. So, if I have just the standard options that I mentioned at the very beginning, then it is clear that there are few chances that patient reacts or lives longer than 1 year. But with these new technologies, we have new chances for this patient to survive and maybe live a few years longer without myeloma, myeloma-free. And the options which we have now, this is bispecific antibodies or CAR-T. So we can provide bispecific antibody in Israel. It is in the basket of reimbursement. CAR-T is not yet reimbursed, but we can use private insurance in this case. So now it's a dilemma. What to do? How to choose between bispecific antibodies and CAR-T treatment for these patients? What is the preferred sequencing? And when we looked at the results of the study, they checked that if we give CAR-T after any other anti-BCMA treatment, for example, we give bispecific antibody against BCMA and then CAR-T treatment, then we appreciate that the response and progression-free survival are much worse and lower in those patients who got this sequence of treatment, anti-BCMA before CAR-T. So right now, the recommendation of International Myeloma Working Group is to try to give CAR-T first and then move to bispecific antibody. Now, the second question, which is quite relevant. We should appreciate patient is now 69 with all possible comorbidities. Would it be risky to provide CAR-T to this very elderly and frail patient? And here, I'm happy to share the results of the study, which is proving that we can provide CAR-T treatment to rather frail and elderly patients, and this is absolutely comparable efficacy for those who are 70 younger and 70 plus. Well, toxicity is quite comparable, so a little bit of more of icons, which is immune cell-associated neurotoxicity syndrome. So we can offer such patient CAR-T as an option. Now, let me go back to my patient and say the following. I want to say that bispecific antibodies also options for elderly patients. We feel quite confident, and we have many patients who are already pre-treated, so we can appreciate that this is effective and safe at the same time, even for senior age patients. So, at the very end, back to our patients, we made a decision to select ide-cel. Ide-cel was chosen because it gives us lower rate of post-CAR-T neurologic toxicity, because patients already experienced very severe peripheral neuropathy, and the cost is a little bit lower, and the patient has private insurance, and insurance unfortunately could not cover more expensive CAR-T. So, patient had 2-week washout before apheresis, so we collected the cells. Then patient was waiting for 3-4 weeks whilst CAR-T manufacturing was ongoing. So that progression was very slow, but it was continuous coordination with the company because we needed to know what is the plan for hospitalization, the deadline. So the question is, do we need to provide something within these 30 days of T-cell preparation? Do we need bridging therapy in all cases? So the real-world data suggests that bridging therapy is very important and may dramatically improve the outcomes of the patients. So very recent data published this year showing that if we start bridging with bispecific antibodies, especially talquetamab, which is against GPRC5D, not against BCMA, then the results are much better, and it controlled the disease very effectively for the majority of the patients. You see very effective disease control and fewer toxicity rate when we provide talquetamab specifically. We, as a hospital that is reference center for bone marrow transplantation, autologous transplantation, and allogeneic transplantation from non-related donors. So for many years, we're already providing CAR T cells for leukemias and lymphomas. So we have some infrastructure which is available, and we can easily provide CAR T to multiple myeloma patients. We have multidisciplinary team, including coordinator, blood bank, pharmacy that are working with us, dietitian, physiotherapists, and the staff of the ward, which is specifically trained, and we know how to manage these patients. We have specific monitoring protocols, how to follow cytokine release syndrome, CRS, or ICANS, which is immune cell-associated neurotoxicity syndrome. We are asking patients to write some sentences every hour to check neurotoxicity. We get CAR T cells from manufacturing via blood bank and pharmacy, so there are very stringent standards how the cells should be received. Then patient is hospitalized, so we use PICC line placement. Well, definitely there is some lymphodepletion and the immunity is reduced, so we try to keep patient in isolation boxes in sterile conditions. Definitely we appreciate if we can arrange accompanying family member, and also we have to prepare hospital to such procedure. That's why neurology, imaging, intensive care, they are ready and they are keeping the bed if we face some severe complications. Now let's continue our story, the story of our patient. So the cells were prepared, patient was hospitalized according to the schedule. So we provided CAR T, and immediately on day one we experienced fever, but it was clear without any clear infection source, so cultures negative. So we assess it as CRS, cytokine release syndrome grade 2. So we treat it with Acamol, antipyretics, together with steroids, together with tocilizumab, because tocilizumab is anti-IL-6 drug with very good results in these scenarios. Then on day 5 of hospitalization, day 5 after CAR T, we appreciate dyspnoea. CT shows signs of airway narrowing and mild angioedema over the thyroid region. So it looked like a little bit angioedema. Yes, we see it very rarely, but sometimes it happens with CAR T. And patient dramatically improved after dexamethasone, so improvement was noted. Patient has very mild ICANS, grade 1, and there were some difficulties with handwriting. I explained you that our patients are writing every hour in order to check immune cell-associated neurotoxicity syndrome, and after steroids, patient dramatically improved, so patient got tocilizumab 1 dose and 2 doses of dexa. Definitely patient continued being with fever and neutropenia. Normally, we used to prescribe antibiotics to these patients for quite a long time, but it has already been proved that wide-spectrum antibiotics, they are not very positive for these cells. So normally we give a very short period of time when we are sure that this is serious fever but not the infection, and we even stop the antibiotic even the temperature is persisting. Also, patient had mucositis with HSV1 positive herpes. We simply increased the Valtrex dose. Also, patient demonstrated fluid overload and we prescribed IV diuretics, but well, all that we see frequently in bone marrow transplantation. That's why it is standard treatment for us. So these patients are getting standard treatment. Here we appreciate neutropenia grade 4 that was ongoing for day 14, anemia, thrombocytopenia very low for about 1 week or even longer. So we didn't require any blood transfusion or platelets transfusion. So patient was discharged 14 days after CAR T infusion. As a result, following the lab tests, we achieved a very good partial remission, VGPR. So as soon as we check bone marrow, I'm sure the patient will be in the complete remission. And for the first time that his free lambda change decreased from 496 milligram per liter to the minimum level, which is not undetectable, which is undetectable by the machine, less than 1.33 milligram per liter. So the ratio is non-detectable. We frequently see it with CAR T and with bispecific antibodies. Patient demonstrated minimal hypogammaglobulinemia, so a little bit of throat infection, lung infection. That's why, yes, we provided immunoglobulins. Also, patient is getting acyclovir and sulfatrimeterphrine as antibiotics, Resprim. And in 6 months after the CAR-T, patient will start active vaccination program. I hope in this short presentation I managed to cover all new technologies, CAR-T and BiTEs, bispecific antibodies. You see, this is absolutely major breakthrough results when we provide CAR-T and BiTEs to these very severe patients. It provides very deep and rapid responses, and survival outcomes improved compared to previous years. And even in very severe patients, heavily pretreated patients, elderly, frail patients, penta-refractory patients, it is still effective. Even for the elderly and heavily pretreated and comorbid patients, this treatment is very effective. We see that CAR-T is durable one-time therapy with BiTEs immediate off-the-shelf option. Everything is available, but BiTEs should be repeated every few weeks, whereas CAR-T is just one-time therapy. These innovations offer real hope and better quality of life for our patients. And I think we have few minutes for questions. And here I'm sharing my electronic mail address, so if you have any questions, comments, remarks, I'm always happy to share. Please write to me. Thank you very much. You also always can contact us and the doctor personally, so we refer all these questions immediately. So we have received several questions. So the first question: when you look at available CAR-T options, is there any safety specificity for each one? Are there any safety profile differences between different CAR-Ts? Thank you very much for the question. That's exactly what I tried to show during the presentation. When I need to select one specific option, I normally look at safety profile. As I showed you in our patient, definitely with cilta-cel, it could be a little bit better if I look at overall response rate and the results that could be obtained, but still the adverse events like neuropathy after the treatment would complicate us, the whole story, and that is why ida-cel was selected in this case, not cilta. If there is no contraindication, so you can also choose cilta-cel, and this is possible as well. So exactly as I showed you before, infection rate is more or less similar between two treatment options, and maybe in the future we will see some differences between two, but yet mainly I look at safety profile and I'm guided by that. Thank you. Thank you very much. Next question related to the selection of CAR-T treatment. What are the selection criteria if you have two CAR-T options available? So which one fits best? Well, the first selection criteria is efficacy. And we see that cilta-cel demonstrates a little bit higher efficacy, but the second selection criteria are the adverse reaction side effects. And maybe the third selection criteria is a cost, because me as a medical doctor, I'm not so much involved into that. But definitely the issues insurance, because now we see that cilta-cel is a bit more expensive than ida-cel, so it's not always compensated by the reimbursement. So I prescribe what is possible. And another question, which is related to the new technologies in the near future. So what are the perspectives of CAR-T treatment and also for myeloma treatment? Well, that's a fantastic question, because what I feel now, we are just at the beginning of this road, and all that will be properly developed. As you can appreciate, we try to switch this new technology to the earlier lines of treatment. Possibly one day CAR-T will be able to replace bone marrow transplantation. Definitely, we are trying to get higher personalization rate of treatment. For example, sometimes it's a very severe patient and CAR-T is not working properly. Then in this case, possibly we can get combination, let's say CAR-T, and then continue with bispecific, which is also possible and could be a strategy for the future. And hopefully new antigens will be found later on that could be our target in myeloma. And also safety profile, we need to improve it, we need to manage effectively, and then we could provide it longer and much safer. So, with this optimistic note, I'm happy to thank you for very interesting presentation. I'm sure it is very useful because mainly we broadcast to the post-Soviet space where CAR-T treatment is not yet widely available, and I'm sure what you told us today is very important and interesting. Thank you very much. Thank you. Have a good day. Stay well. Goodbye. And now I'm pleased to introduce our guest. This is guest from Hadassah Medical Center, Igor Utyashev, who is the physician who is specializing in the diagnosis and treatment of oncological and hematological diseases. He follows the principles of evidence-based medicine and masters modern methods of targeted treatment, immunotherapy, interpretation of CT, PET-CT, including PET-DOTA-TET. He has international experience in patient management and cooperates with Israel Clinic. The floor is yours. Good afternoon, dear colleagues. My name is Igor Utyashev. I'm doctor oncologist, MD, PhD, the lead of clinical trials in Hadassah Clinic, Moscow. Also, I'm the clinical trials department director from MedScan Group and the leader of group for melanoma, skin tumors, and sarcomas, Institute of Oncology, Hadassah, Moscow. Today, I'm honored to speak about the resistant reasons of malignancies to modern immunotherapeutical treatments. Why do we still see cancer although we have anti-tumor immunity and modern methods of immunotherapy? Why sometimes they fail or appear to be non-effective in some particular patients? We know about immune system for about 100 years. We know theories of Ehrlich, Berndt, in the formation of clonal selective immunity, including anti-tumor immunity. And here on the slide, I will try to explain briefly how the tumor cell recognition functions, recognition by the immune cells, and at what steps we could appreciate deviations or failures. Let's imagine the following. This is the anatomy of the anti-tumor immunity. Let's take melanoma as an example, because this is a tumor that I'm dealing with for more than 15 years. And mainly, this tumor is a pioneer in the studies of anti-tumor immunity, and actually all modern anti-tumor treatments actually were tested for melanoma. This is skin tumor, and it expresses tumor-associated antigen on its surface. These are proteins that differentiate the tumor from the normal healthy tissues of the host. So these tumor-associated antigens are recognized by the macrophages in the skin. These are dendritic cells or Langerhans cells. And whilst recognizing the tumor, they destruct the tumor, they digest this tumor-associated antigen, and they split large protein globule into small pieces, and they further, it expresses the tumor-associated antigen on its surface, but it's done already by the macrophage or dendritic cells, not in the skin, but migrating to the lymph node. And here on the picture, lymph node is represented as a large brown structure. In fact, there are many of them. They are of different size, and many of them in the skin. What happens inside the lymph node? Inside the lymph node, we see still continuation of digestion of the tumor antigen, processing of it, and expression in the main histocompatibility complex on the surface of the macrophage. Then we appreciate the presentation to lymphocyte, and lymphocyte at that moment becomes from non-mature to mature. So there is clonal selection, accumulation of these lymphocytes, and then later graduating or leaving this releasing lymph node, the lymphocyte becomes cytotoxic T lymphocyte, because lymphocyte is already armed, equipped, educated, and we have specific receptor on the surface specific to particular tumor antigen or even to the fragment of that. And then traveling around the body, this warrior can recognize the tumor and tries to eradicate it. The concept of anti-tumor immune response exists already about 100 years, but only starting from the end of 1980s, then coming to 1990s, 2000, 2010, 2020. So we are almost celebrating 30 years of these studies, but now we fully understand that interaction of antigen-presenting cell, APC, so that's a cell that tells lymphocyte how tumor looks like, is actually multifactorial, very complex process. And this interaction of APC, antigen-presenting cell, with lymphocyte allowed us to design the concept of immune synapse. So that's exactly interaction, affiliation, and on the surface, on the lymphocyte that need to learn how to recognize the tumor. On the surface of the dendritic cell, we again appreciate so many different molecules, and some of them may launch anti-tumor immune response, activating lymphocyte, or the others could suppress it. Also, this interaction of lymphocyte with tumor cell could also be represented by the same immune synapse. And you see lots of new immunotherapeutical modalities, and they can stimulate anti-tumor activity of lymphocyte. But on the other hand, attention, the tumor itself could turn off the lymphocytes. So this influence to co-stimulation molecules inside this immune synapse allowed us to enjoy lots of new immunotherapeutical modalities from checkpoint inhibitors class. We know that for the first time the concept of efficacy of anti-tumor immunotherapy was proved, in fact, in the very first treatment, ipilimumab, 2011, and for the first time it demonstrated the reduction of metastatic melanoma mortality reduction, and since then the concept is actively developing and evolutionizing. Now we see dozens of classes of new molecules. You see that in immune synapse we see lots of different interactions, so many molecules. So beside anti-CTLA-4 monoclonal antibodies, and beside this receptor, there is PD-1 receptor, very famous anti-PD-1 monoclonal antibodies. There are LAC receptors, TG receptors, and others. Why is it important to see for standard oncologists? Because the classes of new and potential treatments, specifically monoclonal antibodies that can slow down or activate each of these molecules, is really huge. So there is always room for improvement and for further growth. Today, currently, the whole concept of anti-tumor immune response is rolling around the term of anti-tumor immune cycle. Well, we know how anti-tumor immunity works for about 100 years already, but only in 2010, possibly, we started understanding it more detailed as anti-tumor immune cycle. Why did it happen? Because it is in 2011, for the first time, we understood that whilst we are affecting particular chains of well-known elements of immune system, we can get absolutely fantastic, I'm not afraid to say, fantastic clinical results. So the theory of anti-tumor immune cycle for the first time was presented by Dan Chen and Ira Melman. These two investigators clearly shown in their fundamental publications that the launch of such process, the launch of this chain reaction, leads to the fact that immune cycle could function independently and additional stimulation may not be needed. This is the way how the concept itself, concept of anti-tumor immune therapy, is the following. When you start this comprehensive process, which is shown here like a wheel of fortune, like a cycle, will allow immune system independently, without any external support from the anti-tumor drugs, function independently and cure the patients. The term cure, well, we use it very cautiously in oncology normally, because we speak about simple diseases when we speak about the cure, but now we know that right now for earlier non-cured tumors, metastatic processes, some of the patients get into their sustainable and long-term remissions, and there are patients who are getting who got first the checkpoint inhibitors back in 2009, 2010, and these patients are still alive. So very soon we will celebrate 15-year overall survival, 15-year anniversary overall survival, and after the end of treatment, patient gets nothing, and disease does not recur, because some of the patients using modern anti-tumor treatments manage to stop this cycle. The concept of Chen and Melmon about anti-tumor immune cycle is mainly based on practice. It is based on the experience that we got when we saw the efficacy of using immune checkpoints. So the previous years of failures, drawbacks, because we as specialists of cancer immunotherapy, we saw it at the beginning, so probably we need to go back retrospectively and recollect that the first methods of immunotherapy, anti-tumor immunotherapy, actually were investigated back of 1970s. We all know William Curry, famous American surgeon who treated sarcomas using so-called polytoxin. So in fact, giving the patients with malignant solid tumors tumor lysates. This is how he tried to vaccinate the own immune system of the patients, launching anti-tumor immunity. Although later on, at the beginning of the 20th century, when we enjoyed radiotherapy, then later on, 1950s chemotherapy based on ifosfamide, cytostatics, and immunotherapy was forgotten for quite a time. But later on, back in 1980s, we again got the opportunity to synthesize artificially lots of cytokines again, and again interferon, interleukins were in the renaissance, in the peak of interest, but for many years we could not cure vast majority of the patients, and actually immunotherapy was mentioned like something quite complementary for the treatment of malignant tumors. For example, I myself dealing with cancer immunotherapy since 2023, when coming to Blakhin Center in the department of Ilya Demidov. So that was Department of Biotherapy, 2003. So at that time, we tried to activate immune system using cytokines, anti-tumor vaccines. Oh, now it's 2025, and it was 2003. Now, 20 years later, the interest to anti-tumor vaccines again is rising. So we tried to give them T cells, NK cells, but it didn't work. And very senior chemotherapists and surgeons who successfully treated cancer with cytostatics or with local resection or with radiotherapy or with surgery, they were actually laughing, looking at us, saying, no, you cannot activate immune system against the cancer, because if cancer happens, that means immunity fails. It doesn't go, it doesn't work, and you cannot reactivate it. You cannot revive something that doesn't work. But then 2011 epidemiomат registration proved us that not at all. We can launch that cycle, that wheel of immune cycle. The immunity starts working and starts eradicating tumor on its own without any further treatments. So that's the concept which is proving us that this is extremely important. So another concept of anti-tumor immune cycle tells us that one of the most important reasons of non-efficacy of anti-tumor efficiency that my presentation is devoted to is the idea of so-called depletion of cytotoxic T lymphocytes. So they stop functioning normally, and the most important chain in the weakening of the lymphocytes is tumor microenvironment, and I will speak about it in more detail. So since first checkpoint inhibitors came on stage, there was a huge interest in almost every clinical trial that started the efficacy of these options is to look at what happens beyond CT scans, where we see that tumor is shrinking, so CT or PET-CT or MRI, but what happens in the tumor inside? So during all these clinical trials, we were actively taking biopsies of different tumor lesions. So we tried to make biopsy for every patient that is progressing with treatment, and in those patients who are giving us positive response. So with all the patients, with or without response, we took biopsy specimen, and the accumulation of this data led to the fact that back in 2023, again, Ira Mellman and Dan Chen extended the concept of the anti-cancer immunity cycle. They showed that there are so-called immunotypes of tumor microenvironment. So if we simplify, they split them into 3 types, so-called immune desert. So this is what investigators see when they see biopsies of tumors in patients where we see no response to treatment. And we know that there are many of such patients, and for different indications, I would say sometimes it's 50% and sometimes it's up to 80-90% of the patients, those who never respond to anti-tumor immune therapy. What happens under the microscope? Please appreciate this picture on the right. So you see the blue frame on top, that's immune desert. So inside such tumors, we see no immune infiltration, so almost no immunocytes, cytotoxic T lymphocytes, CD8 cells. We see that there is actually repulsion of these lymphocytes via cytokines or different factors from inside the tumor. So there is so-called tissue hypoxia, change of acidity gradient. So tumor, as much as possible, tries to create specific microenvironment around that, like a concrete fence, would prevent penetration any cytotoxic T lymphocytes which are to eradicate the tumor. So there is also the second type of tumor microenvironment, and Mellman and Chen called it immune exclusion or immune excluded in the center. And normally this is infiltration of lymphocytes inside tumor stroma, but they cannot get inside. So they are stopped at the borderline of the tumor, and somehow they cannot get inside to create that storm that would burn this monster called a cancer. Well, the mechanisms are quite simple to immune desert, and here we appreciate very strong mechanical barrier of the tumor inside. So the density of the tumor stroma, which is rigid and prevents lymphocytes getting in, and also this microenvironment releases so many suppressive cytokines which are pushing away lymphocytes from the intruding inside the tumor from the surface, and they cannot get in. And option 3, which is most favorable, shown at the bottom, and that's what we're trying to get dealing with immunotherapy. This is option of so-called immune inflammation, inflamed variant. So we take the biopsy of the tumor, we look under the microscope, and we see massive immune infiltrate, lots of co-stimulating immunocytes, and the creation of so-called tertiary lymphatic structures or intratumor lymphatic structures. Just imagine, we see how lymph node is organized. So inside the tumor, in such patients, we see so-called immune lymph node that inside the tumor is abundant. It's doing processing of tumor antigen presentation and accumulation of so-called warriors, lymphocytes, that inside the tumor are eradicated from inside. And by the results of 10-year follow-up of immunotherapy using checkpoint inhibitors, it was shown that it is this cohort of patients is showing the best results and most sustainable responses, because it is in them we managed to launch that wheel of fortune, wheel of immune anti-tumor immunity cycle. And understanding that, we should keep in mind the mechanisms of how we can create immune inflammation, abundant immune infiltration with the tumor, presence of co-stimulatory immune cells, and formation of intratumoral lymphoid structures, because this is a way how we can cause artificial immune inflammation in many of the tumors, but not the immune desert or immune exclusion. So majority of the labs and groups are working on that, and I will talk about it later on. So, tumor microenvironment. Today, speaking about this term, cancer or tumor, I always imagine not just the tumor cells, but everything that surrounds them, because like the assistants are making the king, so that's the way how tumor, creating the microenvironment around, has the mechanism of escape from immune system. It is in the microenvironment we see the challenge why immune system is not reacting properly. So microenvironment of the tumor is actively studied, and currently we see main elements. Each of them is critically important to start the immune cycle, not to let tumor escape from the immune surveillance. So inside the tumor, well, tumor cells should be somewhere. It is the so-called carcass or scaffold, and inside it's stroma, which is tumor-associated fibroblasts, and there are several populations of them. Then, around the tumor, there are other immune cells, which are so-called myeloid immune cells. 50% of the tumor are macrophages, monocytes, different immature myeloid cells, MDSCs, and 10% it could be neutrophils and dendritic cells. Yes, let's recollect hematology and stem cell theory on how hematopoiesis is ongoing. So each of these populations or subpopulations are very important because they are surrounding the tumor and create there lots of interesting phenomena. Definitely lymphocytes are there, tertiary lymphoid structures. That's a dream of any oncoimmunologist, to see this scaffold inside, because these are in fact lymph nodes which are inside the tumor, and they effectively eradicate the tumor and the tumor cells themselves. So you feel that the most important is kept for the dessert, because in the understanding of many doctors, clinicians, oncologists, chemotherapists, they still believe that tumor is a tumor cell only. Not at all, far from it. As soon as tumor cell is going through so-called epithelial mesenchymal transfer, then gets into the circulation that goes back from mesenchymal epithelial transfer and gets into the stroma of other organ, creating the metastasis, it immediately starts building up the scaffold, like the female of the bee of the ant. They immediately create new beehive, new retinue, new vessels, neovascularization. Nothing should prevent tumor from survival, trying to kill human organism, and we'll discuss each of these chains today. Let's speak about the most important cells. So these are stroma cells. This is something that creates connective tissue where, or like on a scaffold, all tumor cells are holes. So this is tumor-associated fibroblasts, and they create that exactly matrix, the barrier, the scaffold, mechanically gluing it together, chemically gluing it together. So you remember, the cells are communicating in between, if they're not neurons, and they release cytokines, they suppress cytokines. So cytokines are the language in between the cells, and intercellular interaction is done via these chemical molecules. So specifically tumor-associated fibroblasts, they create the clouds of cells, scary, useful lymphocytes, trying to prevent them from getting inside the tumor. Also, they create some pH gradients plus oxidative stress. That means free oxygen radicals, reactive oxygen species that prevent normal functioning of lymphocytes. Tumor-associated fibroblasts, they completely regulate tumor metabolism, stimulate the growth, control metastasis, and in order to make the tumor cell get from the solid organ to the circulation to give metastasis, it modifies, it splits its stroma, and the fibroblasts are supporting it, definitely preventing not only the drugs effect, but also radiotherapy effect. we see lots of different immunomodulating factors, and using modern modifiers, we can change. This is how improving the efficacy of anti-tumor treatment. That very specific cell population, myeloid suppressors, I'm not going to get into the depth of that. This is T, P, NK cells. Each of them release lots of stimulating and suppressing immunity factors. And there is a very big influence here in the fact that these cells, they have particular anti-tumor activity, so they should go into phagocytosis. That means eating up, gobbling up the tumor, but they don't do it due to different effects. And they're also immunosuppressors. They could stimulate the growth of T-regulatory T cells. They, like fibroblasts, they could generate reactive oxygen species, and plus to that, they change the gradient, which is preventing lymphocytes getting inside the tumor. Tumor-associated macrophages are very important cells, and in fact, they have to suppress the tumor, process the antigen, and present it into the dendritic cell. But it never happens because due to very different factors, colony-stimulating factors, endothelium growth factors, as well as expression of receptors to chemokines, they slow down this process of getting cytotoxic T lymphocytes from getting inside the tumor. And last but not least, queen of anti-tumor immunity. This is dendritic cell. That's the queen. And in fact, the dendritic cell should make the balance between the presentation and eating the antigen, launching the immune system. But as I said before, it strongly depends on the co-stimulation, because on the surface of the dendritic cell, we have lots of minor receptors, like handles or buttons. Some of them activate and some turn off. So now the tumor knows how to turn off dendritic cells, and these checkpoint inhibitors, they mainly influence dendritic cells specifically, activating them by the mechanism of CTLA monoclonal antibodies, cytotoxic T lymphocytes, CTL, cytotoxic T lymphocytes. So that's a dream, to create tertiary lymphoid structures, scaffolds, lymphoid scaffolds. TLS provide high efficacy of checkpoint inhibitors, and these tertiary lymphoid structures, TLS, are to be stimulated, and then patients will have many of them inside the tumors. Then immunotherapy works, and this is how anti-tumor immune cycle starts, and we get good responses of the patients. The tumor itself is capable to release both cytokines stimulating immune suppression, and also the tumor can deplete T cells via isolated removal particular nutrients from stroma, from matrix, like tryptophan. Can you imagine? The tumor is so tricky, so devious, it gobbles up all tryptophan in intercellular communication, but tryptophan is extremely important for the cells, and this is how the ratio is changing of T lymphocytes, and inside the tumor, immunity is gone. Also, there is deteriorated expression of main histocompatibility complex, and immune control points, checkpoints, also could be modified. And last but not least, we understand how lymphocyte kills the tumor. Actually, lymphocyte makes holes in the tumor using specific proteins, which are called perforins. These are special enzymes that go through the cell membrane, deteriorate it, and then create gradient of concentration of different electrolytes. So then the tumor is simply bursting out. So the tumor contains special enzymes that actually turn off perforins. So in lymphocytes, even if they recognize the tumor, they cannot kill it, because it immediately uses patches to cover these holes. Or the second mechanism is apoptosis, very well known. We know that every cell should go in for apoptosis, but tumor cell actually immortal, because apoptosis process is deteriorated fast. Associated apoptosis is deteriorated. Why I'm talking about it? Because all that is quite complicated scheme, the picture, and the simple mechanistic understanding that we give the patient chemotherapy and the tumor is dead. Not a way. Immunotherapy works through very complicated mechanism. I liked this picture. King Desaragba and his retinue in Rama's wedding from 1690. You see, there is sort of environment of around the king. So these are soldiers, friends, fools, musicians. They all communicate in between. This is how I understand the modern concept of functioning of malignant cells. And in order to conquer the cancer, we have to agree with each of these players, and this is not very easy, but the steps that were made and the achievements we gained for the last 12 years when we get these modern and very effective treatments for cancer, treatment shows us that we are going the right way. So, starting from 10 years, first publication of the concept of anti-immune cycle, then Chen and I remember they actually changed and they added on their concept with the following. We see that most critical and the most important element of anti-tumor immune cycle is stroma. Tumor stroma microenvironment, and the key success factor is to create tertiary lymphoid structures, TLS. But every step is critically important, and whilst from 7 of these main elements we can influence just 2 or 3 of them, but just imagine if we simultaneously, in the same patient, in the same tumor, we will influence each of these important points. So that's the idea, that the development of oncoimmunology will finally allow us to get very sustainable remissions in the vast majority of the patients. So we fully understand that, and now I will tell you that we can easily influence each of these elements of anti-tumor cycle. So the green color are the stimulating factors that stimulate the launch of particular step, and the red color are the factors that inhibiting it. So finding the balance in this very comprehensive, complex mechanism, finally we can enjoy the success in the treatment of cancer. Well, thank goodness the science is moving on, and we have very effective methods how we can influence each of these 7 most important steps of functioning of anti-tumor immune cycle. So the first mechanism is so-called release of cancer cell antigens or cancer cell death. Yes, we have chemotherapy, we have cytostatics. They lead to the destruction of the tumor, so radiotherapy is doing almost the same. Now we are actively dealing with so-called anti-tumor oncolytic viruses. So these are special viruses, genetically modified. You can immediately recollect the film about apocalypse. I am the legend, so you can see what happens when we have effective treatment against the tumor. So that's a spoiler. I can remind you that there was anti-cancer virus, and then people turned into monsters after that in that movie. Fantastic movie, by the way. The second mechanism here, it's the presentation of tumor antigens. So they are released by the tumor cells. So this is cancer antigen presentation, dendritic cells. So we have vaccines and the vaccine that is now discussed in Russia very actively. We also have different ways to stimulate this process, the presentation of the antigen, priming and activation of lymphocytes. It could easily be done with the help of cytokines. This is what we've started with in the 90s of 20th century with this type of immunotherapy, cytokines. We fully understand that using mechanisms which are stimulating or blocking angiogenesis, but we fully understand that tumor needs vessels, because otherwise it will not survive, and this is how it's trafficking from one organ to the other during metastasis. So slowing down angiogenesis and giving targeted treatment that block the vessel growth, neovascularization, we can stop this important mechanism. Also, we step away from tumor microenvironment, because there we fully understand that using cytokines we can deteriorate these multiple barriers and make them permeable And then mechanism 6 shown here, that's exactly what CAR-T treatment is doing. So we can artificially modify lymphocytes, introducing chimeric antigen receptor there, and colleagues hematologists now successfully using it for the treatment of different hematological tumors, CAR-T treatment. And last but not least, mechanism 7. So this is how we open the curtain of effective immunotherapy. So these are checkpoint inhibitors, killing of the cancer cells. Why this slide is important? So the science doesn't stay still. Oncoimmunology is most actively developing. And today we're working on each element of this cycle. So when we via targeted way or via cumulative effect, we can activate all of them and get very good anti-tumor effect. But again, not everything is so simple. Tumor-associated antigens, TAA, that's anti-tumor response, that's from they're very different. But the common challenge here is that normally they have very low immunogenicity. And on the surface of the tumor, although they are expressed and the immune system and T-cell receptor should recognize and kill them, but we see that histocompatibility complex exists there, because if not it would be destroyed, but it's modified and lymphocytes cannot recognize them properly. Also there is so-called immune selection or immunotolerance that also prevents from classical immune response in response to this tumor-associated antigen, TAS. But based upon that, there are anti-tumor vaccines, and I promised to tell you a little bit about it. We are waiting it eagerly in Russia. This vaccine is a replica, of course. So this is a copy of American vaccine, and I would like to speak up a little bit of it. So what's the concept of anti-tumor vaccine? We fully understand that the more antigen we see in the tumor, that means unique peptide complexes, fragments of peptides, that exist due to mutation. So the higher is the mutational burden in the tumor, because we can measure mutations in the tumor. This is so-called TMB index. We measure it due to genomic sequencing of the tumor. And the higher is the rate of mutations per megabase, and if we understand that if it's higher than 10, then the immunotherapy would be working nicely for these tumors. So we sent tumor specimen for sequencing to see how many mutations are in there. So that's fantastic publication of 2017, published in England Journal of Medicine. So that's one of the most important medical, not oncological, but medical journals. I highly recommend it to read, because lots of new concepts shown there. So the authors show that high correlation between the objective response rate to anti-PD-1, anti-CTLA-4. So this objective response rate correlates directly with the median number of coding somatic mutations per megabase. That means TMB index. So the tumor with the highest rate of mutations shows us the highest response rate. And look here, it's melanoma, definitely colorectal cancer, and some other tumors, for example, Merkel carcinoma, kidney cancer. So in fact, all these tumors of head and neck specifically, immunotherapy is dominating here and showing fantastic results, and totally opposites. If tumor has very low mutational burden, what does it mean, no mutational burden? Very few antigens, so immunogenicity of these tumors is very low. They are shown to the left. So that's mRNA vaccine that we are talking about. So some time ago in Russia, there was an announcement that Russian scientific group designed mRNA vaccine against cancer. But I should repeat once again that we are not the first who designed these vaccines. In fact, for the first time, the concept of this vaccine showed clinical efficacy, but in Russia we haven't yet carried out clinical trials, but it was done already by our American colleagues at ASCO. So this is American Society of Clinical Oncology Congress, and they showed the first results already, American colleagues. So what's the vaccine? So there should be oncology patients, there should be a tumor. The tumor is resected, and based on tumor genome sequencing and interpretation, we create particular libraries of patient-specific and tumor-specific antigens. Well, speaking simple language, the authors of this project identify 34 most frequent tumor-associated antigens, TAAs, and they designed mRNA to each of them. So that means artificially, in the laboratory conditions, they managed to synthesize antigens, not the tumor, but the pieces of antigens that could activate immune response. And then, from 1 to 34, these mRNA were packed specifically into the special carrier, special vector delivery system, and then it was administered to the patient after the tumor resection, to the patient, back to the patient. So what happens now? This artificial mRNA, matrix RNA, that gets into patient's lymphocytes, into patient's tumor, into stroma tissue, and they are released on the surface, and this is how they could immunize immune system of the patient against very typical pattern of his own tumors. What happens next? Activation of the immune response, and that's the fabulous study that make a revolution. That's Keynote 942. This is phase 2 study. So these are patients after radical treatment of metastatic melanoma with stage 3 with involvement of lymph nodes. So one group of the patients got matrix RNA vaccine plus pembrolizumab. That was combination treatment arm. The second group was getting just pembrolizumab monotherapy. So the main objective here was to check relapse-free survival, RFS, and the secondary endpoints was overall survival and survival without remote metastasis, distant metastasis-free survival. And finally, we see this mRNA vaccine improves the result of checkpoint inhibitors in adjuvant regimen. And we looked at relapse-free survival. That was primary efficacy endpoint. And we also showed distant metastasis-free survival. So it is like surrogate marker of overall survival, and I totally agree with that. So right now, we're trying to reproduce this concept in Russia to guarantee this vaccine not only to patients with resected tumor, but also in the metastatic scenario, which sounds very interesting, and I'm happy that our research center could get such option. The other anti-tumor vaccine, which was already registered, this is T-VAC vaccine. That's a virus that contains inside specific substance which is called GM-CSF. That's very powerful chemoattractant. And GM-CSF from T-VAC promotes the maturation of dendritic cells, which in turn, in conjunction with other options, improve the outcomes. So pre-op administration of this vaccine improves further surgical outcomes. So wrapping up, let me speak about the third concept, last but not least, but we strongly hope to develop this concept in Russia. Yes, it's already available in the world. This is so-called TIL treatment, tumor-infiltrating lymphocytes. Again, we take the fragment of tumor from the patient, and here we select tumor cells, and among them we found exactly those lymphocytes. And I told you before that the king is made by the retinue, and this is a pool of cells that could recognize and kill the tumor cells. So artificially we can already accumulate these TILs, tumor-infiltrating lymphocytes. We can collect them and accumulate them, and after the minimal lymphodepletion, so this is how we put down T suppressors, regulatory, we re-inject these TILs, tumor-infiltrating lymphocytes, and we see fantastic outcomes with co-stimulation of IL-2. We can appreciate rapid shrinkage of the tumor size. So that's a very interesting trial. Just phase 1, which was presented at the European Congress of European Society of Medical Oncology, ESMA, back in 2023. You see, these are deeply pretreated patients, metastatic melanoma. They already got some line of treatment, but it was failed. And then these patients were getting either TIL treatment or ipilimumab, which is second-line anti-CTLA-4 monoclonal antibody. And you see how different are these curves, progression-free survival, how they are splitting from the very beginning, especially in favor of those who were getting cell treatment. Look at the objective response rate. And now, attention, these results still amaze me. So we actively recommend this method to our patients. In 17% of the patients, complete responses, objective response rate 41%, And almost in 60% of the patients, we see clinical efficacy. So here, as a minimum, we managed to stop the progression of the disease. And this is just giving to the patients their own lymphocytes. They were infiltrating in the tumor, although patients already progressed in the prior lines. Definitely, we are developing it very fast, and we know there is already TIL manufactured commercially, Lifilio-cel, Amtagvi, registered in US, available in Israel, unfortunately not available in Russia. So we are still searching for new inhibitors. Inhibitors of checkpoints and so-called LAG3 inhibitors. So we have these options available. Now I want to show you this picture. So this is my patient with metastatic melanoma with huge axillary tumor conglomerate, very painful conglomerate. So this patient came to us in autumn 2023, and actually for 2 years already, this patient is a very good anti-tumor response in good somatic status. So he came to the visit back in summer, and I want to show you that the size of the tumor reduced 3 times, and we suspect, and also by PET, we suspect that there is no viable tumor, so it's just dead tumor lesions because they like changing during palpation. So from the very dense stone-like, it became very soft. But why do we have this tube here? Let's imagine sometimes patients have tumors like a watermelon or even melon sometimes. So for patients, we have just this amount of 15 milliliters of lymphocytes that could kill the tumor. But even this small amount of the cells, 15 milliliters, 1 tube, can create a miracle, curing patients. So oncoimmunology is extremely perspective. We are actively doing it in Hadassah Clinic in Moscow, in our Institution of Oncology. Me, as clinical trial director, I can speak about lots of new projects. So if you have any patients who are interested, so we can offer clinical trials to them. We are actively cooperating with our colleagues in Israel specifically. So if you have any questions, comments, remarks, you're welcome. Thank you. Dr. Utyashev, thank you very much for your lecture. It was very interesting and informative, very useful. Thank you. It's a great pleasure to talk to you. So, dear colleagues, our conference has come to an end. If any of you did not have the opportunity to ask your questions, please refer to us, contact us, and we will do everything necessary to respond to all your questions that you are interested in. For those of you who are interested in cooperation, professional development, lectures, medical products, collaboration in the area of medical tourism, and everything related to medicine, please feel free to reach us out. We are always open to cooperation. Thank you for your participation, for your interest. We will send a questionnaire to everyone, so please share your feedback about our lectures, the lecturers, and the overall level of the conference. If you have any suggestions, ideas, please let us know. We'll be glad to take your opinion into account. Until our next meeting, goodbye, yours, Mark Kаценельсон.